Hi there, I'm Jacqueline Garcia from Dana-Farber Cancer Institute, and I'm here with my fantastic colleague.
Hi, I'm Andrew Brunner from Massachusetts General Hospital.
And we are very excited. We have a really lively panel this afternoon, and there's a lot of speakers, so we're going to start now. We're about 10 minutes over our time. I know a lot of people have flights, so I will be keeping people on their times. So we'll go ahead and start with Dr. Tian from Stanford University, who's going to give us some new knowledge on IDH mutations, CCUS, and MDS, where it fits, what it means, and what we should do.
Might be slightly different than that. I'm hoping to, while I wait for the slides to be pulled up, which is not displaying yet, there we go. I'm going to tell you a little story that is part basic science, part translational, that developed into a clinical protocol that is ongoing right now. And the title of the talk is Inacinib, which is obviously used in AML and in IDH2 wild-type MDS. The outline is that I'll talk about the scientific impetus and the work that led to this ISR concept, which is now in full swing, and I'll show a little bit of the results from the phase 1b portion leading to the RP2D and some conclusions. And so I think this audience does not need any introduction to how IDH2 wild-type and the mutant enzyme works. The wild-type enzyme works in the TCA cycle by converting isocitrate to alpha-ketoglutarate, which is a cofactor that then acts with the TET2 enzymes to demethylate genomes and result in differentiation. The IDH2 mutant enzyme, however, does not allow alpha-ketoglutarate to be made. It makes a uncle metabolite instead, named 2-hydroxyglutarate 2-HG, that stops this DNA methylation process, which then leads to progenitor differentiation block and initiation of blast proliferation. And so, of course, Inacinib was a intelligently designed IDH2 mutant inhibitor, inhibiting the IDH2 mutations, this not really allowing 2-HG to accumulate, decreasing the differentiation block, and then allowing neutrophils to be differentiated. So there was this interesting finding in the original relapse refractory AML trial looking at Inacinib, which is that ignoring the people who achieve CR, PR, which we all understand, AML patients who have responses have better hematopoiesis, decreased transfusion needs, and that's a no-brainer. But what was striking and interesting to us is that in about 40% of the total trial patients with stable disease that had quite a bit of disease burden, a good proportion of these folks became transfusion independent, which is very dramatic in AML patients without achieving CR. So this made us wonder whether there was other effects of Inacinib that could be explored. So essentially, we, for time's sake, I'll just skip through to the experimental design. We simply wanted to see if Inacinib by itself can differentiate CD34 positive HSPCs from the cord blood to make red blood cells by doing a very simple in vitro erythropoiesis assay, taking CD34 HSPCs from cord blood and differentiate them in the setting of IL-3, stem cell factor, and EPO. And then essentially just doing the culture in 96-well plates and looking at erythroid differentiation by two markers, CD71, the transferrin receptor, and GPA, as illustrated on the top right for gating schema. And as you can see on the bottom panel, we compared the presence of Inacinib and the presence of the placebo or carrier, DMSO. And you can clearly see that by looking at the double positive population illustrated in red, CD71 positive and GPA positive, the presence of Inacinib actually increased erythroid differentiation from CD34 positive cord blood quite a bit. We kind of didn't believe this result, so then replicated it many, many times using over 20 cord bloods and saw exactly the same. We did the same thing on the right-hand side using human adult bone marrow enriched CD34 positive cells and also differentiating them in vitro and saw similar effects in increased erythropoiesis. In looking at the mechanism, potentially we saw that this increased erythropoiesis was associated with a increase in hemoglobin levels intracellularly, and it correlated with the increase of myeloid transcription factors, GATA1, EPO receptor, and KLF1 during erythroid differentiation. We wondered whether this had anything to do with the 2-AG, the oncometabolite, by adding the oncometabolite onto the cultures. And as you can see in the results on the right-hand side, the addition of the 2-HG had no effect on the ability of inatinib to increase erythropoiesis in our cultures. We then wondered whether this was a totally off-target effect by using CRISPR-Cas9 AAV1-based to knock out or delete endogenous wild-type IDH2 in 3 independent cord bloods, is shown on top. You can see that we get successful IDH2 wild-type protein expression deletion. We then take these cord blood into our in vitro erythroid differentiation culture, and you can clearly see in red there that in the setting of wild-type IDH deletion, inatinib still had similar effects in augmenting erythropoiesis. We did a bunch of flow experiments characterizing cell surface phenotype combined with colony-forming assays to show that the effects of inatinib starts working at the level of the, you're not seeing, sorry. If you're looking at the plots on the bottom, you see that inatinib is acting primarily at the pro-erythroblast differentiation stage in GPA positive and BAN3 positive cells, where it had pretty much no effect on the BFUE and CFUE colony formation, indicating that this is acting at a later differentiated erythroid progenitor. We wanted to chase down some mechanism by looking at intracellular heme synthesis, because that in the literature has been associated with increased erythroid differentiation in its own right. And on the left, you can visually see that the addition of inatinib, or the presence of it in the erythroid differentiation cultures, leads to more red, which indicated to us there was more hemoglobin or heme synthesis. And using mass spectrometry on the bottom bar graphs there, and then also immunofluorescence and looking at PPIX on top, you can see visually that the production of protoporphyrin, whether it's iron or zinc incorporated, or increase on a per cell basis as reflected on the bottom. So in conclusion, we show that inatinib can drive endogenous erythropoiesis in a wild-type IDH2 independent pathway. And combined with the clinical trial observation that it improved erythropoiesis and platelet generation in the AML trial, we wondered whether inatinib can actually be helpful in other types of patients who do not have the IDH2 mutation. And that was the basis of this phase 1b/2 clinical trial that's been ongoing for the last about a year and a half, 18 months or so. And the trial design was actually pretty simple. We all know that inatinib is a fairly well-tolerated drug in AML patients and also MDS patients. So we simply wanted to question whether, if given continuously orally, it can also do the same for IDH2 wild-type MDS patients with lower risk disease. And as you can see, the eligibility is pretty generic and broad in that you just have to be an adult with lower risk MDS, I should say lower, not low risk, with fairly good performance status and have anemia, neutropenia, or thrombocytopenia by the IWG criteria. You were excluded if you had the IDH2 stereotypical canonical mutations, mostly because that would affect the readout of the trial accurately and bias the response to those with an IDH2 mutation. And of course, you can't have anemia due to other causes. And so the study schedule, as I said, is pretty simple. It's a continuous drug, well tolerated once a day that patients pick up on cycle X day 1 and they take. They get labs every 2 weeks or so, and simply with CBC, CMP, and a variety of other iron studies that we're using as biomarkers and the correlates. The patients get a bone marrow biopsy at screening, and then subsequently, depending on responses, and we discuss this with them. And of course, we're collecting, for biobanking purposes, both peripheral blood and also for first pull aspirate, and trying to get at the mechanism of where this drug or how this drug might be working. And so here's the clinical trial design in enrolling the lower risk MDS patients. And I should just explain that the trial, when started, was meant to look at activity and tolerability in both lower risk MDS folks and then also non-proliferative dysplastic CMML patients. But with CMML being a very rare disease, the accrual has been very slow, and so we've chosen to essentially shut down that part of the arm and focus on rapid accrual on the lower risk MDS arm of this protocol. And so all the data that I'll be discussing today from the trial is the phase 1b portion in the lower risk MDS and not CMML patients. And you can see that essentially the design is very simple. We start off with a 100 milligram daily dose, which is the FDA approved dose that is known to be well tolerated. We do the generic 3x3 randomization to look for just to see if the 200 milligram dose would be just as well tolerated and could potentially have more efficacy by increasing the dose to 200 to determine the tolerated RP2D. And so I'll focus on the results preliminarily for the phase 1b portion. The study objectives, as you heard a little bit, it is listed as following. Primarily, we wanted to know whether enicenib was safe and well tolerated, as I indicated, and whether it was effective in improving anemia or decreased transfusion dependency, as defined by the IWG. And as Andy Brenner alluded to this morning, you'll see that I feel that it is also a very high bar to reach of how much hemoglobin we're asking these patients to make. We wanted to look at the time to erythroid response and the duration of response, and of course the proportion of people who can reach this TI independence as defined by no transfusion greater than 8 weeks. The baseline characteristics for these patients are pretty straightforward and very consistent with lower risk MDS patients. You'll see that small numbers, there were 3 in the 100 milligram cohort, 4 in the 200 milligram cohort. It's a study that included primarily, unfortunately, predominantly male Caucasian patients with good performance status. If you look at their IPSSR and IPSM score, they both fit into the lower risk category, and I'll show you the genomics in a second. The vast majority of the patients, with the exception of one treatment-naive low-risk MDS patient, had failed ESA, luspatercept, and one person had failed, had no response to single-agent HMA. And we also defined the subcategories of transfusion dependency by the 2018 IWG. You can see that cytogenetically, most of the patients belong to low risk IPSSR as defined by IPSSR. And looking at somatic mutations, you see that the patients are enriched for the CH mutations, DTA, and then also what's expected spliceosome mutations and some others. That's more rare. We wanted to obtain baseline labs with CBC, of course, to track responses. And we wanted to look at total bilirubin and QTC prolongations, as these were the known toxicities associated with enicenib. And describing the AEs that came out of the phase 1b portion of this trial, I would say that primarily the drug was super well tolerated, as we know enicenib to be, with 75% of the patients exhibiting an increase in total bilirubinemia as a result of decreased excretion. We really didn't see much problem with the QT prolongation that was checked for the first 4 cycles of the trial. The rest of next prominent as far as side effects was the GI side effects that are well described actually for IDH inhibitors that included nausea, diarrhea, and some constipation. Of course, we looked for signs of differentiation syndrome by looking at fluid accumulation, shortness of breath. We wouldn't expect this to happen given this population is IDH2 wild type and not IDH2 mutant. And we looked at the incidences of bacterial infections and other infections in this population, and it was noted to be very similar. And so as the result of the toxicity analysis, essentially, we felt that the 200 milligram dose, which is above the FDA-approved dose, was actually well tolerated and became our RP2D for the phase 2 portion of the clinical trial. And I just wanted to give you an example of a very prominent trilineage responder on the clinical trial, patient number 3, which, as you can see, this is the longest running patient on this clinical trial, ongoing at 16 cycles of continuous inisinib. And you can see that he actually does meet the IWG 2018 criteria by increasing his hemoglobin by a little bit more than 1.5 grams, but it took a very long time to achieve that bar, about a year after starting continuous therapy. And you can see that, interestingly, although this was hard to interpret in the AML trial, of course, because that is your cancer cell of origin where the blast became neutrophils as part of the differentiation. But interestingly, this particular patient's neutrophils also increased in a similar pattern and kinetic along with the hemoglobin. And I'm not showing the platelet data here because he had very mild grade 1-2 thrombocytopenia at baseline, but we saw a similar pattern. And so this was a really interesting example of a trilineage responder in an IDH2 wild-type patient, which leads to the question of whether IDH2 has a totally off-target effect that may be acting at the progenitor level, MPP, CMP, perhaps, to explain the trilineage response in improvements in all the cell types. And so, as I mentioned, the RP2D for inisinib in this IDH2 wild-type lower risk MDS trial was determined to be 200 milligrams, and we're in the middle of the phase 2 accrual for this clinical trial, and it should conclude at the end of this year. So conclusions are inisinib can definitely drive urethroid differentiation of late-stage erythroblasts, and it's independent of IDH2 wild type. It's well tolerated with expected toxicities in IDH2 wild type patients with lower risk MDS, and that it may be increasing endogenous erythropoiesis and granulopoiesis as indicated by that data in lower risk MDS folks. And then the phase 2 portion of the study is ongoing, and I look forward to talking about the results in the near future. And so I'd like to thank the clinical research trial team shown on the left here, and of course all the patients who gave me permission to use their photos, as these patients are, as Andy alluded to, quite difficult to take care of in some capacity, in that the quality of life and fatigue really matters, in that providing even increases in hematopoiesis or erythropoiesis by decreasing and prolonging the interval between transfusions can make a significant impact in their quality of life by not be tied into a transfusion chair. And so with that, I'd like to thank the organizers for inviting me for this talk. So I'll take any questions.
Thanks very much. We probably have time for one question if anybody would like to.
Thanks for that nice talk. Do you still feel like in the original, I think, paper, you hypothesized that ABCG2 was the target? Do you still feel like that's what's...
No, that was the putative mechanism we put into the JCI paper. And if you use similar inhibitors that inhibit ABCG2, you do see an increase in erythropoiesis, and that's what led us to make that conclusion. But since starting the clinical trial and other ongoing experiments in the lab suggest that that is not likely a specific mechanism, and that it probably has to do with metabolic effects, actually looking at the kinetics of how erythropoiesis or increased hematopoiesis is happening. Yeah.
Thanks very much.
Okay.
I've grown some red cells in culture, but right here.
Oh, sorry.
But do you get more cells or the same number of cells but more differentiated, or actually fewer cells because they grow slowly but they have more time to differentiate, if that makes sense?
Both the number of cells, so the number of absolute RBCs you get out of the culture is about 2 to 4-fold. If you look at absolute heme synthesis in the mass spec data that I showed, it's actually 4 to 8-fold. So not only are they making more cells on a per cell basis, there is more absolute hemoglobin. Yeah. It's just difficult to do because it takes 100 million cells to do a mass spec study. And so, yeah.
Thank you very much.
Okay.
That's great.
Thanks.
Our next speaker will be talking to us a little bit about a new therapeutic avenue potentially in the low risk MDS space, a Venetoclax. We're lucky to have Dr. Yazmin here from UT Southwestern.
Hi, everyone. Thank you so much. I'd like to start by thanking the AAMDS Foundation for holding such an awesome meeting, and for the co-chairs of this session, Drs. Brunner and Garcia, for their invitation for me to be here today. So I'll be discussing the role of imetelstat in lower risk MDS. And this was our new cancer center, but now I guess it's a year old, so no longer a new cancer center. I'll need to come up with new pictures, but it's a beautiful building. Here are my conflicts of interest. I did serve on the steering committee for the iMerge imetelstat trial, phase 3 trial. The outline for today will discuss the efficacy of imetelstat, but really focus on the cytopenias and the safety profile for patients with lower risk MDS, and also discuss what VAF reductions and their correlations with outcomes really mean. As you're all well aware, we do not have too many drugs that are approved for MDS. And in the US, other than HMA therapy, we've had lenalidomide in 2005 and then luspatercept in 2020. And 2023 was our lucky year with ivosidenib for relapsed refractory IDH1 mutated MDS. And hopefully this year will be another lucky year for MDS patients with having imetelstat hopefully approved. So what are telomeres? The term telomere was coined by Hermann Muller in 1930, about 100 years ago. And a couple of fun facts about telomeres is it comes from a Greek word, and I really want you to pay close attention to the correlations here. So Greece is in the Middle East, I'm Middle Eastern, and Hermann Muller was at the University of Texas at the time he discovered this. I'm at the University of Texas right now. He did win a Nobel Prize, and I won. Let's move on to the next slide. So telomerases were actually another area where Nobel Prize winners have received a Nobel Prize in 2009 for the discovery of telomerase enzymes, which maintain telomere lengths. And that brings us to imetelstat, which is a 13-mer oligonucleotide that's a first-in-class direct and competitive inhibitor for telomerase activity that specifically targets dysplastic cell clones with abnormally high telomerase activity, enabling normal and effective hematopoiesis. The iMerge phase 3 study design was a double-blind, randomized, placebo-controlled study carried in more than 100 centers across 17 countries, really looking at patients with low and intermediate 1 risk MDS per the original IPSS, who were either ineligible to receive ESA therapy due to a high baseline EPO level, or were relapsed or refractory to ESA therapy. Those patients were non-deletion 5q MDS patients and were randomized in a 2-to-1 fashion to receive imetelstat as an IV infusion over a 2-hour period once every 4 weeks versus placebo. And the primary study endpoint was the 8-week transfusion independence, which I'll refer to as an 8-week TI. The baseline characteristics were pretty balanced between the study groups. The median age at study enrollment was 72. Most patients, 90% in both arms, had received prior ESA therapy, and only 7% had had prior luspatercept therapy. The RBC-TI rates in the intent to treat population was remarkably and significantly and clinically more meaningful in the imetelstat compared to the placebo arm. So the 8-week TI was 40% compared to 15%. Of note, the median duration of TI for that cohort was almost a year. Looking at the 24-week TI rate, that was 28% versus 3%, and the median duration of that transfusion independence for those patients was about a year and a half. And the 1-year transfusion independence rate was 18% for imetelstat compared to 2% for the placebo arm, and the median duration for that cohort was 2.5 years. The increases in hemoglobin levels were quite meaningful as well, where the patients achieving an 8-week TI had a median of 3.5 grams of increase in their baseline hemoglobin. Looking at the 24-week TI, that increased to 4 grams, and at the 1-year TI, that increased to 5 grams. So it seems like the responses kind of deepen with time and the hemoglobin continues to rise. So I hope I convinced you that it's an effective therapy for patients with lower risk MDS. However, is it safe, and how, and are there any safety concerns? There were grade 3 to 4 AEs in the imetelstat arm that were higher than placebo, mainly hematologic, and we'll delve into the details in the next few slides. Importantly, only 14% of patients discontinued treatment due to an AE. The hematologic AEs were most frequently thrombocytopenia and neutropenia, grade 3 to 4 in 60 to 70% of patients. And dosing consideration, this is quite important because although some of the AEs did result in treatment delays, the mean dose intensity in all patients was 90%, and the mean dose intensity in those who achieved an 8-week TI was 95%. So how did the neutropenia and cytopenia occur? When did they occur, and how were they managed? The most common cytopenias occurred in the first 1 to 3 cycles. Importantly, the time of onset was within the first 4 to 6 weeks of starting the drug, and the duration of the cytopenias were less than 2 weeks. Less than 2 weeks for neutropenia and or thrombocytopenia, and they lasted for less than or equal to 4 weeks. Severe bleeding events were infrequent and occurred at the same rate as patients treated on the placebo arm, and the same was applicable for febrile neutropenia, with only 1 patient on the imetelstat arm having febrile neutropenia. So how were the cytopenias managed? The use of supportive care per patient was allowed, and for the discretion of the treating provider. About a third of patients received GCSF support and 18% received platelet transfusions. Importantly, the median GCSF support per patient on the imetelstat arm was 3 doses, and the median units of platelet transfusions was 1. Another AE of special interest is elevations in LFTs. I would note that the majority of those events were grade 1 and 2 and reversible, with no Hy's Law cases identified. So moving to the most exciting, or what I think is the most exciting part about imetelstat, is the ability to reduce variant allelic fractions and what that means in MDS. We haven't had a lot of drugs approved in MDS that can show molecular responses or cytogenetic responses, and this, I think, is moving the needle in a positive way for patients with MDS. So the SF3B1 VAF reduction really significantly correlated with the longest TI duration, in addition to the increases in hemoglobin. Another correlation that was seen for patients with an 8-week and a 24-week TI is the correlation of those responses with cytogenetic responses with reversal or reduction in the ring sideroblasts in the bone marrow, as well as the 50% or more reduction in the SF3B1 variant allelic fraction. So I'll give you an example of a real patient case, and that's one of my patients who are treated on the trial. Of note, the VAF, or the variant allelic fractions in the study, were done on the peripheral blood. This patient had all their bone marrow sequencing done from marrow samples. So it's a 71-year-old female who had MDS SF3B1, diploid cytogenetics, more than 50% ring sideroblast at diagnosis. Before trial enrollment, she had MDS for about 2.5 years and was low risk per IPSS. The prior treatments included ESA therapy for 6 months without a response, luspatercept for 6 months, and the dose was escalated to 1.75 milligram per kilo for 3 doses with ongoing transfusion dependence. She actually had alloimmunization as well, and it was becoming more and more difficult to get her blood units. She was enrolled in the iMerge sub-study, and basically after a couple of months and with the the results of the trial being positive, we were able to unblind and cross her over to the imetelstat arm. And the last units of blood received were actually on cycle 2, day 1 for a hemoglobin of 6.6, and that was the end of it to date. She has an ongoing response. What I wanted to highlight here is the mutational profile and what we've seen at the bone marrow level. So she had an SF3B1 mutation, K700F, a missense mutation at 45% VAF, and 2 TET2 mutations, a splice region variant, and the frame shift mutation, also in excess of 40% at the baseline bone marrow. The hemoglobin at that time was 6.9, and the bone marrow had, by morphology, more than 50% ring sideroblasts. At the 3-month mark, we noticed VAF reductions in all 3 mutations equally, which makes the results a little bit more valid, I think, down to the teens, so 16%, 16%, and 13.5% for the other TET2 mutation. Importantly, she was transfusion independent at that time. The hemoglobin was up to 9.6 and less than 10 ring sideroblasts by morphology. At the 6-month mark, the VAF further reduced to the single digits now, 7%, 6%, and 5% for the 3 mutations. And the percentages were kind of a little bit higher for SF3B1, but that continued at the 3 and 6-month marks. The hemoglobin was now close to 11 after 6 months, and the 4% ring sideroblast by morphology. At the 9-month mark, we had no NGS testing, but 0 ring sideroblasts were seen by morphology, and the most recent hemoglobin from a couple of weeks ago was 14.2 at cycle 11, day 1. So between the time we started the trial with a hemoglobin of 7 to 14 in a 9-month period, to me that indicates disease-modifying potential. So the iMerge, in summary, the iMerge phase 3 trial met its primary endpoint, demonstrated benefits with 8-week, 24-week, and 1-year transfusion independence. The safety profile is, I would say, well characterized, and cytopenias need to be monitored closely for the first 3 cycles, but the important part is they were reversible in less than 4 weeks to grade less than or equal to 2. And the clinical consequences with close monitoring of those patients were not increased for imetelstat compared to placebo. The VAF reductions are, I think, they significantly correlate with clinical benefit, and I do believe that it has a disease-modifying potential. Questions remain: what will happen in the long term for those patients with longer follow-up? Is this going to lead to a survival advantage? How are clones going to evolve? How are patients going to lose response eventually? Are a lot of questions that remain to be answered. And with that, I thank you all for your attention, and I'm happy to take any questions.
Thank you very much. If we have we can have time for a question if anyone has one.
Thanks for the great talk. Could you, I'm just curious, how do you think it's actually working in terms of improving erythropoiesis? Do you have any, I'm not familiar with this, but do you have any thoughts about it?
Yeah, I would say in MDS, it's usually decades later that we know the exact mechanism of action, but for now I would say, the MDS HSCs or stem cells are supposedly have higher expression of telomerase enzymes, and so with a telomerase inhibitor, that's really targeting the MDS stem cells. Now, what's interesting is the responses were seen irrespective of the telomerase activity. So it's not necessarily a marker for response, but that's thought to be the mechanism of action. Thank you.
Thanks. I just have a quick question from the pathologist perspective. Did you see any sort of differences in the subtype of MDS? Like the you gave an example of SF3B1. Do the SF3B1 mutants tend to respond better, have more likelihood of transfusion independence, or any particular genetic subgroups?
I would say yeah, that's an important question. I would say responses were seen in the trial irrespective of the ring sideroblast status, whether it's RS positive or negative, irrespective of transfusion burden, because patients needed to have a high transfusion burden at baseline of 4 or more units in an 8-week period to enter the trial, and they stratified them from 4 to 6 units versus more than 6 units, and responses were seen across both groups. So it's really not 100% clear at this time. I would say 60 to 70% did have an SF3B1 mutation entering the study. And I think in part that was because the MDS diagnosis needed to be centrally confirmed. And I think patients who have ring sideroblasts, it's a much easier central path confirmation of MDS versus assessing dysplasia. A lot of patients actually screen failed because of lack of central path confirmation. Thank you.
Thank you so much. We're delighted to introduce Dr. Angela Consagra from the University of Florence, who will speak to us about luspatercept and its role in MDS.
Good afternoon, everybody. Thanks to the organizer for inviting me to speak about luspatercept. I'm very glad to be here today. So, luspatercept is a relatively new drug who acts as a trap for ligands of the TGF-beta superfamily to reduce SMAD2 and SMAD3 signaling and enhance the late stage of erythropoiesis. As it was demonstrated in a phase 2 study, the PACE, luspatercept was more active in patients with a diagnosis of myelodysplastic syndrome with ring sideroblast. For this reason, in the medalist trial, luspatercept was compared with placebo in patients with a diagnosis of MDS-RS, transfusion dependent, who, after failure of ESAs or where patients are intolerant to ESAs, patients were enrolled in a double-blind primary phase. 2-to-1 to receive luspatercept or placebo, and luspatercept was administered at the starting and standard dose of 1 milligram per kilogram of body weight every 3 weeks subcutaneously. The disease assessment was performed at weeks 25, and after that, patients who obtained a benefit from the drug without progression could continue in the double-blind double-blind secondary phase, and the blind was open only in the long-term follow-up phase, where patients could be kept longer on treatment when they maintained their response. The primary endpoint was the transfusion independence longer than 8 weeks, and it was obtained in 38% of patients in the luspatercept arm, regardless the SF3B1 allelic burden, total number of baseline somatic mutation. The period of transfusion independence, the median transfusion independence was longer in the luspatercept arm versus placebo 1, around 30.6 weeks. When you look at the safety of the drug, you can note that luspatercept is a very safe drug, and the most common adverse event was fatigue. That in the medalist it was present in the quite good number of patients, and as the others adverse events, it decreased over time proceeding with the treatment after the first 4 cycles of therapy. So, to better evaluate the efficacy of the treatment with luspatercept, as a secondary endpoint, the improvement in neutrophil and platelet count was evaluated. And some patients obtained a mild increase both in platelet and neutrophil count. Together with the things that hematological adverse events was not observed with luspatercept, we could say that luspatercept could be a safe drug for patients who are not wholly anemic but thrombocytopenic and neutropenic too. So luspatercept is more active when the transfusion burden is less than 4 units per 8 weeks. And when the period of treatment was prolonged more than 48 weeks, the rate of response increased to around 48%. MEDALIST trial led to luspatercept approval by FDA and EMA in 2020 for second-line therapy in transfusion-dependent patients with a diagnosis of MDS-RS after ESA's failure or when patients are intolerant to. And it was registered to transfusion-dependent and non-transfusion-dependent patients with thalassemia. So, as I said before, rates of response increased with the treatment time, and over 40% of patients who responded achieved a transfusion dependence longer than 1 year. In this slide, you can see that overall survival in patients who obtained a transfusion independence with luspatercept was prolonged, but as we know from the past, every kind of therapy who induced transfusion independence could be active on the overall survival, could be prolonged the overall survival. In the MEDALIST trial, the median progression-free survival in the intention to treat population was not reached. So we want to look at what happens in real life court. And from a collaboration of Fondazione Italiana Sindrome Mielodisplastica and Moffitt Cancer Center, I had the opportunity to evaluate a very large cohort of patients, 331, treated with luspatercept. In our cohort, transfusion independence was obtained in a rate that was super impossible to the MEDALIST 1. Luspatercept was more active again in low transfusion burden patients, but we have to note that even in patients with a high transfusion burden, luspatercept could induce transfusion independence and an important reduction of the transfusion burden. To better evaluate our cohort, interesting data are about the response and its relationship with the mutation of SF3B1. So patients who harbor the mutation have a trend in better response to luspatercept, especially when they present the mutation in the most common hotspot was the K700E. Going deeper in the evaluation of the commutational pattern of our cohort, we divided patients according to IPSSM and WHO 2022 in 3 groups. The SF3B1 beta group is the one where patients harbored the mutation of SF3B1 and another, such as SRSF2, BCOR, BCOR1, STEC2, negative mutation. In the alpha group, patients present only the mutation of SF3B1 or another different from the beta. And where the third group, where patients presented the mutation of SF3B1 together with the deletion of 5q. So, in our court, a patient of the SF3B1 alpha has a higher and significant response to luspatercept, while patient with the L5Q and the co-presence of mutation of SF3B1 don't seem to respond to luspatercept treatment. Evaluating overall survival, patients who respond to the treatment have a longer overall survival, especially when they obtain a transfusion independence together with the increase in hemoglobin value more than 1.5 gram per deciliter. Luspatercept was evaluated again in the common trial compared with epoetin alpha in first line of therapy in all patients with MDS, with amyloidosplastic syndrome, low risk transfusion dependent patients, is naive. And the disease assessment was performed every 24 weeks. But the very important things of this trial was that the primary endpoint was very stringent because it was a transfusion independence more than 12 weeks with a concurrent hemoglobin increase of more than 1.5 gram per deciliter. Other secondary endpoints together with safety were evaluated. So the primary endpoint was obtained in more than 60% of patients in the luspatercept arm. And when patients were dissected better, we can note that luspatercept is more active compared to epoetin alpha in patients who had a transfusion burden more than 4 units per 8 weeks, as we expected that the past trial, such EPO-HAIN for epoetin, the trend of response for this kind of patient with epoetin alpha is around 20%. And when evaluating the endogenous EPO, again, luspatercept is more active than epoetin alpha when endogenous EPO was between 200 and 500. The presence of mutation of SF3B1 remain a prognostic factor of response to the drug, together with the presence of ring sideroblast. The important thing is that patients who didn't have ring sideroblast seem to respond better to epoetin alpha. The duration of the primary endpoint was longer in the intention to treat population in the luspatercept arm versus the epoetin alpha arm. Because of these encouraging results, now there is another trial that is ongoing now, the Element, that is a phase 3 trial comparing again luspatercept and epoetin alpha in non-transfusion dependent lower risk patient with a diagnosis of MDS. So, for ending my presentation, to reflect on available evidence at present, what may we say about the ideal patient for luspatercept? So, in first-line therapy, I would choose luspatercept in transfusion-dependent patient with a low-risk MDS, with a transfusion burden more than 4 units per 8 weeks, and especially if they have a long history of transfusion dependence, and especially if that patient has a mutation of SF3B1 in the alpha group, or if the endogenous EPO is above 200 units per liter. In second line, I choose luspatercept after ISAS failure in transfusion-dependent low-risk MDS. But now, if a patient is wholly anemic with a higher transfusion burden, if it's possible, I would choose imetelstat that is in its pre-approval phase. From the real-world data, we know that luspatercept could be active in third line after failure of HMA or lenalidomide in a rate that is in a range of 20–40%. Remind the problems of the patient with a del5Q and the concomitant SF3B1 mutation. They don't seem to respond to luspatercept, and we don't have data in the first line because these kind of patients are excluded were excluded in the past trials. I'm end my presentation, and thank for your attention, please. Sorry.
Thanks. We have time for a question.
Thank you. So are there any patients with an EPO level less than 500 who have low risk MDS who would still choose EPO as the first line agent despite the results of the COMMANDS trial?
Above 500?
No, below 500. So they would have been, let me rephrase, a patient who would have been eligible for the COMMANDS trial, but you would not give luspatercept as the first therapy to.
So how I said before, I choose luspatercept when the endogenous EPO is more than 200 because it is more effective than EPO18 alpha, and I choose luspatercept again if the endogenous EPO is more than 500.
No.
But we know that luspatercept is less effective in this kind of patients too.
Well, it was better than erythropoietin when the level was less than 200 too. You showed that in the slide.
As first line of therapy, maybe if the endogenous EPO is less than 200, I choose EPO18 alpha, especially in elderly patient, or if this patient is not transfusion dependent, for example. So
I agree. I mean, especially if they don't have an SF3B1 mutation.
Yeah. And
even though those patients fall under the category of someone who could
and this is important, especially in Europe, for example, patients can administer the EPO18 alpha themselves at home. So I think that if you can try before luspatercept, EPO18 alpha, maybe for elderly is better.
Thanks very much. It's a nice segue into our next debate.
I'll spare my colleague on introducing himself. I'll take the honor of doing that. So we're going to move into a debate. Thanks for everyone for your many very good questions and our speakers. We're moving into a discussion on when should we start new therapies in lower risk MDS and maybe even in CCUS. There's going to be some viewpoints, pro-con, and this is going to be presented by my colleague, Dr. Andy Brunner here, and Dr. Zoe Shi, who will be virtual. I just want to confirm here that she's there. Hi. Dr. Shi, can you hear us okay? Can you unmute by chance? Hi there.
Can you hear me?
Definitely. Yep.
Perfect. So I think now I need to share my screen. Sorry about that. Let's see. Can you see my screen?
Yes.
Got it. Okay. Should I start now? Everybody hear me okay?
Yes, please.
Perfect. So thank you for the AMDS Foundation for the hosting the great meeting, and thank you for the study chair for the invitation. Although I'm not able to be there in person, but I'm so excited to join you virtually. Me and Andy decided to make our topic focus on the CCUS because there's a lot of controversy in this area. So our debate is treating CCUS. Are we there yet? I'm assigned to pros. I would say almost there. First, my name is Zoe Shi. I'm an assistant member from the Malignant Hematology Department at Moffitt Cancer Center. Here is my disclosure. So to make the debate a little bit interesting, we made a case. So this is a 75-year-old man, a professor at a university, baseline, very fit, presented with persistent anemia, performance status, and hemoglobin steady decline over the past 5 years, and he is very symptomatic at this time. He came in with a hemoglobin of 9, MCV normal, RDW normal, WBC, and platelet are all normal. So workup for the anemia has been ruled out other etiologies for the anemia. A subsequent bone marrow biopsy was performed. OR showed maturing trilineage hematopoiesis, 1% of the blast, and no significant dysplasia are noted. Cytogenetics normal. Next generation sequencing showed type 2 mutation with a VAF of 36%, SRS2 missense mutation VAF of 22%. Given the workup, he was given a diagnosis of clonocytopenia. So basically, he is asking us, doctor, I can't play golf anymore. I will try everything that could potentially help me. So the answer, I was thinking about, how do we help this patient? Try to focus on 3 areas. Number 1 is, can we do something to help his symptoms? Now his functionality has declined because of the anemia. And also, can we do something to prevent the disease progression? And can we do something to prevent the cardiovascular risk profiles? So we'll discuss based on these 3 items. So first of all, the anemia in older adults is very common. From the large perspective study, it has shown that the overall prevalence of anemia increases by age, as you can see on the figure on the left side. And on the right side is actually a senior adults clinic, and which is specifically to evaluate the patients with anemia in older adults. And the study was about 8 years ago, and at the time the next generation sequencing is not widely available. So at the time the study published was found that 45% of patients, their anemia is due to a known etiology. So now the NGS is now widely available and no longer cost limiting in most of the settings. So it has been performed as part of the standard of evaluation in workup of patients with abnormal cell count. So in this subsequent study published in 2017, it actually showed that individuals with anemia were more likely to harbor somatic mutation, indicating of the clonal hematopoiesis compared to the matched control groups. So definitely, if we ask, can we do something for patients with a clonal hematopoiesis and also with anemia, why not, to help their symptoms? And the next question is, what is the risk for the clonal hematopoiesis or clonocytopenia to progress to myeloid malignancy? So currently we have 2 risk stratification models for the clonal hematopoiesis. So one is called CHRS, the other one is called MN-Predict. So using this CHRS as an example to see what is the risk for this patient's risk to progress to myeloid malignancy. So using the very robust data set from the UK Biobank, about 200,000 patients are included in this study with a follow-up of 11.5 years. The investigator has identified the risk factors for clonal hematopoiesis to progress to myeloid malignancy. So basically, this calculator is available online, and you can plug the risk factors. Basically, the risk factors are whether patient has a single DNMT3A mutation, high-risk mutation, the mutation number, VAF, RDW, MCV, cytopenia, and age, and then they will give us a kind of like a score and to tell us whether the patient is at a high risk or low risk. So from the CHRS study, it showed that if the number is over than 12.5, the patients are at a higher risk. Between 10 to 12 is intermediate risk, and for patients with CHRS less than 9.5, it is a lower risk. So go back to our patients, we plugged all the numbers into this risk calculator, and it tells us, okay, this patient is actually at a high risk for disease progression with 5 years of progression-free survival, about like 25%, at 10 years, about 50%. So this is something that not, we can just ignore this, risk to progress to myeloid malignancy. So we'll talk about, is there any therapy that we can prevent the disease progression? But before we talk about that, let's talk about, the clonal hematopoiesis on other health conditions, the impact of the clonal hematopoiesis on other health conditions. So while patients with clonal hematopoiesis may not experience any symptoms, there's really a growing body of data indicate clonal hematopoiesis has a broad indication on age-related disease, also called inflammation, such as cardiovascular disease, specifically for like stroke, heart attack, autoimmune diseases, osteoporosis, lung disease, or kidney disease. Certainly, we talk about the risk to progress to myeloid malignancy. So one of the most phenomenal finding was the association between the clonal hematopoiesis and the cardiovascular disease. So clusters of paper have provided strong evidence in favor of the inflammation hypothesis in cardiovascular disease. So on the left side, it showed that the type 2 knockout mice develop larger atherosclerotic lesions than the wild type, possibly related to increased leukocyte recruitment. And the type 2 deficient macrophage are more inflammatory by producing more IL-1 beta, which leads to increased monocyte recruitment and larger lesions. So in this New England Journal paper, this is called a CANTOS trial. It's a cardiovascular trial. So patients received IL-1 beta inhibitor, the canakinumab, were shown to have lower cardiovascular disease events. And in the exploratory analysis from this CANTOS trial, a subset of the patients with clonal hematopoiesis were studied and found that the canakinumab can decrease the major cardiovascular events in patients with type 2 mutation. So now from a treatment, are we ready to treat patients, like this? From the three major point I want to point out is that, number one, from this anemia, symptomatic anemia perspective, I think, from the trial perspective that we have at least the 3 trials are available for this patient. So the first one is a planned IIT using luspatercept in patients with CCUS. Basically, the treatment strategy will be the same as treatment in MDS. So this is something in planning. The second trial will be there is a trial using canakinumab in patients with the CCUS, high-risk CCUS. So this trial, as we discussed, the canakinumab can reduce the inflammatory status and also hopefully can reduce the cardiovascular events. So I think, this patient will be a very good candidate for this trial. The last trial is using ascorbic acid in patients with type 2 mutation. Just want to give a brief introduction for this trial. Is the rationale is that the type 2 is methylcytosine deoxynase enzyme that oxidizes 5-methylcytosine to 5-hydroxymethylcytosine, a very crucial steps in DNA demethylation. So ascorbic acid serves as a critical cofactor for type 2 and binds to its catalytic domain, restore and enhance the type activity. So given the high prevalence of the type 2 mutation in CCUS, so this study was a hypothesis that ascorbic acid could induce, ascorbic acid could induce the epigenetic modulation by enhance the oxygenase activity and therefore enhance the activity of the type 2 regulated by the wild type allele and reinforce the functional redundancy in type 1 and type 3. So in a recent study, in a recent conference, it's called Intercepting Blood Cancer Meeting 2024, we also heard about the update from a trial using oral vitamin C plus hypomethylating agents has significantly improved the overall survival in patients with myeloid malignancy. So hopefully all of these trials could eventually targeting the biology and hopefully to prevent the disease progression. So there are also other trials, other IIT clinical trials for patients with CCUS. For example, using the afacitinib and axitinib, also using metformin statins in patients with CCUS. So overall, the question is, are we ready to treat CCUS? The answer is from my perspective, I'm glad that the session chair assigned my talk to as a pros, as my daily job is to how to improve the care for patients with CCUS. So I do think as a clinical investigator, we have preliminary data to design trials, particularly for high-risk patients, patients with high-risk mutation or in therapy-related clonal hematopoiesis or post-CAR T, for example. I think our goal, if we could improve the symptoms, targeting the disease biology, and hopefully eventually to prevent the disease progression and reduce cardiovascular events, why not to treat patients with clonal cytopenia? It will be my dream that we can design clinical trials in a prospective way that we gain experience in setting the appropriate endpoints for different studies and also set CCUS-specific response criteria in different contexts. So this is my part, and we'll hand it to Dr. Brunner for the cons.
All right. So I will flip over, I guess, and present the con card of, are we ready to treat CCUS, treating anemia and clonal hematopoiesis? I have the not there yet, or maybe considerations to think about. My disclosures again. So we heard about the case, right? We have a 75-year-old. He's got symptomatic anemia. You can't find another cause except for this clonal population in his bone marrow. And he comes to you and he says, Doc, how do I get rid of this mutation? You talk about this every time we visit. I've got this anemia, Doc. What do I do? And so, I think it raises a number of questions, and it's good as a field that we're thinking about clonal hematopoiesis and CHIP and CCUS, and it's good that we're trying to do something about disease earlier, but we have to think about what the implications are for that. Who would we treat for clonal hematopoiesis? How would we assess a benefit, a response? What is worth the burden of me starting to do something to your disease? And how does it impact our existing few but growing treatment options in MDS? What happens when you start to use them early on? And I think a lot about it, that there's a lot of overlap, and we heard some really good talks about inherited predispositions to malignancy. And I think that CCUS and CHIP have a lot of overlap where the penetrance of your disease really impacts the risk-benefit of your intervention. And so this is an example. This is for transplant for inherited conditions, but you can think of the same for patients who have initiation on chemo or even growth factor, to be honest. If we start someone early on a treatment, are we providing benefit to a highly penetrant thing? And how does that change when we have a lower penetrant type of mutation or type of chip? And a great example actually is del(5q, and we have some data to guide us. And I think really interesting, I don't know that I have the answer from this data, but the Sintra-Rev trial took patients who have MDS with del(5q but did not need transfusions. And the main benefit of lenalidomide that we know of is that it gets rid of your transfusion needs, particularly in patients with del(5q. And so in this study, we have a highly penetrant disease. If you have del(5q, you're going to develop transfusion dependence at a relatively high rate and in a relatively short period of time. And so here they intervened with 2 years, so a time-limited period of low-dose lenalidomide, and they found that the time to needing transfusions was over 5 years for those who they treated with that 2-year intervention, and it was only about a year. So you saved a year of waiting when you were given placebo. And so you could significantly delay the time until patients became transfusion dependent. A challenge was there's no survival difference. So is it worth for some patients with anemia but not transfusion needs to get 2 years of a treatment or not? That's a discussion I guess you could have, but we have data to guide this highly penetrant state of disease that has not yet reached kind of transfusion needs. A challenge is that a lot of clonal hematopoiesis, even with our models, has a much lower penetrance. So here, the CHRS, a huge benefit. I talk to patients all the time about their disease, their CHIP, and what the chances are of monitoring and how should we manage the potential risk in the future. But it's still a pretty long horizon. It's 10 years until 50% of patients develop a myeloid neoplasm. And so that is a basis that we can use for trial development or for patient selection, but it's a long time horizon, and to power that kind of study in colon hematopoiesis, we're going to have to be pretty creative. It's almost more of a screening study, like colon cancer screening, doing colonoscopies to try to find an event every 10 years. And in contrast to this event horizon, and just something that we have to think about, Sintra-Rev, the median time to transfusion dependence is 1 year. So you didn't have to wait too long to know if your intervention mattered. Another challenge that we have, and that we're seeing as we move things into earlier treatment paradigms in lower risk MDS, is that the less transfusion dependent, the lower burden a patient's disease has at baseline, the harder it is to distinguish from placebo. So again, getting back to this study of roxadustat, patients got roxadustat or placebo, and the response rate in the placebo arm for 8-week transfusion independence was 33%. So if it's that in an MDS cohort, in clonal hematopoiesis or CCUS, what should we expect the placebo to do? Will patients just have spontaneous improvements? How are you going to know what you're comparing yourself against to say this intervention has benefit and let's do a randomized study? When we think about what responses we would use, the response threshold, what a quality response is, becomes really much higher, because most patients in CCUS are going to be transfusion independent. There'll be no transfusion dependent patients, and then you really need an intervention that lasts a long time and that has a marked improvement in hemoglobin. It's not like we don't have that. It's a big consideration in how you power and design a study in this space. Do we design trials that need 12-week, 16-week, 24-week, 1 year transfusion independence? Is it a time to transfusion dependence type of marker? Do you need to be 1.5 grams per deciliter, or should it be 3 grams per deciliter? And does it have to get rid of the clone, or are we going to wait 10 years for 50% of people to get a second malignancy? Another consideration that we need to think about is how do we then integrate it with, once a patient officially has MDS down the road, what do we treat them with? If you got luspatercept and EPO already for your CCUS, am I then bound to give you azacitidine and transplant as soon as you develop low risk MDS? Or will those work again if we did a time-limited period? So I think just when we design the trial, we also have to think about what options we will have down the road. Hopefully more, but it is, if we shift our therapies earlier in disease, but we're not actually prolonging lives, are we running out of options for patients when they need them more? And so, there are a number of unanswered questions in this space. Is all therapy in low-risk MDS forever therapy? I think that it's interesting, like the Sintra-Rev data, but there's also data out of Italy looking at patients who stopped lenalidomide while in response. And many of them, kind of like cessation trials in CML, would have long periods of transfusion independence before they needed to resume therapy. Should we be thinking about more treating to a goal and then giving people breaks when we're thinking about low-risk MDS? And would that provide the ability to re-challenge patients? Is our goal going to be disease modification, which is a pretty high bar? That's what we do for high-risk MDS. Or are we just looking at symptom control trials for CCUS, because that's what we do in low-risk MDS kind of as we do? And how many patients do we have to treat before we feel like we're over-treating, quote-unquote, cancer-free population? So are we ready to routinely treat CCUS? At this time, not universally, is my argument. We need trials, and it's good that there is so much interest in this space, but we have to think about what we're doing. We also have to think about novel designs that are maybe a little different from what we're used to in low-risk MDS and in high-risk MDS. We have to think about the placebo and what the expected benefit would be worth it for intervening. And then I think hopefully we have more options in later stages of treatment of myeloid neoplasms, but it may impact what we have to pull from if we're treating people early. So anyway, thank you very much.
Thank you. This panel's open to questions. Dr. Zaida in the back. Can you pull Zoe back up, please? Thank you.
So yeah, both perspectives are great, but to you, Andy, in particular, like I think we need to think of these as syndromic, right? So it's not like about delaying heme malignancy or transfusion dependence, but all of these non-cancer associated cardiovascular morbidities, and I do think these have to be taken into account, and you probably have to have these composite endpoints that they are so good at cardiovascular trials, right? Like delayed time to MIs and all of that stuff. So I think with that perspective, I don't think those trials become very, very difficult to do, because I think the number of events would become much bigger. And I think, as was shown earlier, most of these patients are dying from cardiovascular stuff rather than blood cancer. So I think this is another important thing to kind of think about.
100%, and I hope that we are focusing on that in some of these studies that we're doing. It's an open question, I think, whether our interventions toward their anemia will actually then impact a cardiovascular endpoint. But I hope it, I agree.
So I want to go back to Zoe's patient, because that's what we're talking about. The patient's not feeling well. They don't have a bona fide diagnosis of MDS because the pathologist couldn't find the dysplasia. But but we all know that this patient has clonal hematopoiesis with high VAFs. So it's in the natural history of this disease is similar to that of MDS. Now, I'm a nihilist, but if a patient walks in the room and says they don't feel well, do you tell them, well, you really don't have a disease yet, so I can't treat you? Or do you say, let me try to make your hematocrit go up, or maybe give you luspatercept, even though I don't love that drug. Maybe we'll get rid of your cytokines. Do you think that's justified?
I think we can both answer it. It's true in the clinic. It's a big challenge, and it's hard to know the likelihood of a response or what to get out of people. But when you get down to it, yeah, you end up trying to intervene, and there's not necessarily a lot of guidance. And I agree with you. This patient has burgeoning MDS. If you look at their survival compared to low risk MDS, it's the same. And so how do we, it's less about do we use the arsenal that's on our shelf, I guess. And it's more, we need more options for these kinds of patients that meet that the right burden.
It depends what the goal is. The goal is so the guy won't get leukemia someday, sure, but it's also to make him feel better. When we know that the chance of him being fatigued is as much because he's 75 and he's losing his livelihood because he's retiring or something. So,
Although I might start luspatercept and he still feels fatigued with a better hemoglobin or EPO.
Well, clinical medicine is hard, no question about it.
Sorry, I specifically make my case easier to support my point. But I feel like people are ready to run some trials with different endpoint.
Yeah. I guess we all have those patients in our clinic. Gathering the data from their treatment histories is something we still lack.
A question I'm going to ask until the mic moves over to Dr. Salmon to both speakers. What do you think about the role of PROs in this case? We do a horrendous job of addressing the biggest problem of fatigue for the patients. What role might PROs actually have in the CCUS arena? I think that could be, in particular, very impactful, designing a better tool, and that might be another pathway for regulatory purposes.
It's definitely a space where, compared to like MPNs, they have a much better, even in the quote-unquote low-risk MPNs, but they have a high symptom burden, much better tools than we tend to use routinely in MDS. And I agree, it would be good if we had a more consistent evaluation method for that.
I guess for either of you, kind of to Rich's point, so we've enrolled a couple of patients on Kelly's IDH1 virtual study, which is nice. So anybody can enroll in that patient, and it's actually gone pretty well. But on both of them, I first pray that they don't meet MDS, and then one of them, I had to have a conversation, and I'm like, we squint. So I guess my concern is, or my question is for the real high risk group, it's such a blurry line. How feasible is it going to be to run these trials, and then what is going to be the meaningful? I know there's not necessarily an answer, but that's even on like the few CCUS trials that are out there, like that's the patients that really need the therapy are so much in that low risk MDS. Do we need to think about them together or not? But just a question.
Yeah, actually, a nice way to think about it would be is if we had an expansion or incorporated more CCUS patients on low-risk MDS trials. So, maybe meeting clinical criteria like transfusion needs or certain hemoglobin or what have you, but then having the ability to enroll them on a trial based on clinical needs and less on strict diagnosis, I think would be one such way.
Yeah, I agree. Like I specifically meet some difficulty barriers from, the regulatory perspective to design CCUS specific trials. So I think if we could, set an arm for MDS study, including high risk CCUS patient will be easier. And also, hopefully we could, as a group talk to, has a more like a regular meeting, talk to the FDA and then to understand, okay, how do we treat patients like this? And particularly, I really like Dr. Garcia's point, like, to improve or maybe design some specific PROs and to improve their symptoms could, maybe convince them to run these trials for such patients.
Thanks so much to you both. We're going to move on to our next speaker. We could clap if you'd like now, so Zoe could hear since it's on. Okay. We're going to move into our high-risk MDS session. Dr. Yasmin Abaza from Northwestern has joined us to give us an update on advances or limited advances in the treatment of high-risk MDS, areas where we might have failed or where we might go next. I'm just going to put in a plug. We are about 25 minutes a little over time. We recognize people have flights, so I'm going to be a little bit more
I'm fast.
Tight on
Don't
that.
worry.
Okay, thank you.
I'm very fast, and so thank you very much. Good afternoon, everyone. I would like to thank the co-chairs and the organizers for the very kind invitation. So today I'll be presenting limited advances in the treatment of higher risk MDS. These are my disclosures. So higher risk MDS remains an area of high unmet need, with hypomethylating agents being the only approved agents for frontline therapy. In the landmark AZA-001 trial, azacitidine significantly improved overall survival compared to conventional care regimens, 24.5 versus 15 months, with a CR rate of 17%. This 24-month overall survival has not been replicated with subsequent studies showing an overall survival of 11 to 19 months. Data from the MDS consortium show that the median overall survival with HMAs was 17 months, with similar survival for both azacitidine and decitabine. And although decitabine has not shown overall survival benefit in a randomized trial, which may be due to the decitabine dosing schedule used, both HMAs are used interchangeably. Oral decitabine cedazuridine has been recently approved for higher risk MDS based on the initial phase 2 and subsequent phase 3 ascertain study, which showed pharmacokinetic and dynamic bioequivalence to IV decitabine. In this compound, cedazuridine inhibits cytidine deaminase, preventing the degradation of oral decitabine. The overall response rate with decitabine cedazuridine was 70%, CR rate 25%, and a median overall survival of around 32 months. However, about 40% of the patients treated on the study had lower risk MDS, explaining the longer survival and higher response rate. This oral HMA is a major advancement because it decreases the burden associated with parenteral HMA therapy and facilitates the development of future oral combinations. Allogeneic stem cell transplantation remains the only potential curative treatment option for fit patients. In a biologic assignment trial comparing reduced intensity ages 50 to 75, the 3-year overall survival rate was significantly higher in the donor versus no donor arm, 48% versus 27%, supporting the role of transplant. There's still several areas of active research with regards to transplant, including the role of transplant in patients who have lower risk MDS using IPSS-R and then upstage to higher risk using IPSS-M, the need for cytoreduction prior to transplant, the molecular subgroups that may not have long-term benefit from transplant, and the role of post-transplant maintenance to improve outcomes, especially in patients with high-risk mutations. And some of these areas will be discussed later on this afternoon. There have been extensive efforts to advance the frontline treatment of higher risk MDS beyond HMAs with an exhaustive list of failed studies. Recently, there have been 6 randomized phase 3 studies comparing AZA doublets to AZA monotherapy. And despite encouraging phase 1-2 studies, 4 of these phase 3 studies failed to achieve their primary endpoints, including pivininostat, APR-246, magrolimab, and sabatolimab. Of the two remaining trials, the Verona trial assessing azacitidine plus venetoclax has completed accrual and results are still pending, and the only actively accruing trial is tamibarotene for retinoic acid receptor alpha positive higher risk MDS. There are very limited information published or presented so far to help us understand the reasons behind the lack of success of these 4 major randomized trials. However, some plausible reasons include the clinical and molecular heterogeneity of MDS with no molecularly defined subgroups that may benefit from these agents, including hypomethylating agents, and the poor understanding of the adaptive and primary mechanisms of drug resistance. In addition, there's some potential pitfalls in clinical trial design and primary endpoints which may have impacted the results of these studies, which include, for example, the enrollment of CMML and oligoblastic AML, which have different disease biology and response to therapy, the random distribution of genomic events without molecular stratification, which may impact outcomes if there's an imbalance in high-risk mutations, the lack of a unified primary endpoint of overall survival, and the use of surrogate endpoints such as CR rate, which is not a good surrogate marker for overall survival, and the CR rate with AZA monotherapy in these trials was much higher than that of historic data. The lack of double blinding some of these studies, which may result in early dropout, and the need for longer, positive, and larger phase 2 studies prior to proceeding with phase 3 studies. And whether any of these limitations played a role in the negative outcomes associated with these phase 3 studies remains largely unclear. There's still hope to see positive results with azacitidine and venetoclax given its success in AML. In a phase 1b study, azacitidine with 14 days of venetoclax 400 milligrams showed promising results in treatment-naive higher risk MDS, with an overall response rate of 80%, CR rate of 30%. 50% of patients achieved Marrow CR, of which 37% had hematologic improvement. Over 50% of patients achieved post-baseline transfusion independence. Responses were rapid and durable, with a median duration of CR of 16.6 months. Median overall survival was 26 months, with overall survival longer in patients who achieved CR or Marrow CR with hematologic improvement. And these promising results provide the basis for the randomized phase 3 Verona study, which was designed to confirm an overall survival benefit with azacitidine plus venetoclax versus azacitidine placebo in treatment-naive higher risk MDS, and the results of this study are still pending. Importantly, 41% of the patients treated with Aza-Ven on this phase 1b study proceeded with allogeneic stem cell transplantation after a median of 3 cycles. The majority of patients who proceeded with transplant were below the age of 65 years and achieved CR or Marrow CR prior to stem cell transplantation. The median overall survival was not reached for those who achieved CR or Marrow CR and subsequently proceeded with allogeneic stem cell transplantation, with over 70% of the patients alive at 2 years, which provides the rationale for using HMA-Ven or Aza-Ven as a bridge for transplant in patients with higher risk MDS. And even if the results of the Verona trial are negative, we do still anticipate the continued off-label use of Aza-Ven in patients with excess blasts of 10% or more, especially in patients who are eligible for stem cell transplantation. HMA failure is another major area of unmet need. Prognosis of HMA failure, higher risk MDS is poor, with overall survival of 4 to 6 months. There are no true standard of care options in stem cell transplant ineligible patients, with the exception of the recent approval of ivosidenib for IDH1 mutant relapse refractory MDS. However, this only benefits 1 to 3% of patients, with the majority of higher risk MDS patients having no standard of care options. There are several emerging novel agents for relapse refractory higher risk MDS, which are currently being investigated in early phase trials. Some of these agents can target specific mutations, such as IRAK4 and CLIC inhibitors, which can target splicing factor mutations, which are present about 50% of MDS patients. BCL2 dependency after HMA therapy supports the addition of venetoclax at the time of HMA failure. And in a phase 1b study in relapsed refractory MDS, azacitidine plus venetoclax had an overall response rate of 39%. Majority of the responses were Marrow CRs, where 43% of the Marrow CRs had hematologic improvement. 21% of patients were bridged to transplant, and median overall survival was 12.6 months, comparing favorably to the historic survival of 4 to 6 months. And this supports the potential role of Aza-Ven in the relapse refractory setting. However, whether this Venetoclax add-on strategy will be used in the future will largely depend upon the results of the Verona trial. IRAK4 inhibitors are very interesting agents under investigation for relapsed refractory higher risk MDS. Preclinically, U2AF1 SF3B1 mutations have been found to cause aberrant splicing of IRAK4, leading to the overexpression of the IRAK4 long isoform, which causes constitutive activation of the midriasome and subsequently of the NF-kappa B pathway, promoting leukomogenesis, which makes the IRAK4 long isoform an attractive target for therapy. Emavusertib is a novel oral inhibitor which inhibits both IRAK4 long isoform and FLT3 and is currently being assessed in early phase trials in patients with relapse refractory higher risk MDS with very limited data published so far. In conclusion, higher risk MDS remains an area of urgent unmet need. With limited agents approved to date, we only have HMAs in the frontline setting and ivosidenib for relapsed refractory IDH1 mutated patients. We have not been able to find an HMA doublet regimen that can improve response rates or overall survival in a randomized trial. And whether azacitidine plus venetoclax will be the first doublet approved for patients with treatment-naive higher risk MDS depends upon the Verona trial. And if positive, this may be the new backbone we use to develop future triplet regimens. There's still several areas of active research on higher risk MDS, which include identifying clinical and molecular biomarkers, predictive of response to agents, including HMAs, better understanding of resistance mechanisms in higher risk MDS, the need to develop more molecularly targeted therapies with the hope of improving outcomes, optimizing transplant with regards to patient selection, timing of transplant, and the need for cytoreductive and maintenance therapies, and optimizing clinical trial design, including statistical assumptions, primary endpoints, and molecular stratification. And with this, I'd like to conclude my talk. Thank you very much for your attention and time.
Great, thank you very much. Do we have any questions? It is a nice segue to Venetoclax and its role in MDS, and thinking about how MDS genetics might impact who benefits from Venetoclax. So we have Dr. Senapti from the MD Anderson Cancer Center here to talk to us about Venetoclax and MDS genetics.
Good afternoon, everyone. Thanks to the co-chairs, Dr. Stone, Dr. Young. I must tell you that when I was training before in India, I've had the opportunity to listen to Dr. Young several times, but meeting him first in the United States now. Thanks to the session chairs, Dr. Garcia and Dr. Brunner, for considering me for this talk. I understand it's this. Right. So no relevant disclosure. So my talking points will deal primarily with the genetics of MDS and AML, a little bit of it because it forms the bedrock on which Venetoclax can be spoken about. Some work on my work on splicing factor gene mutations in AML and how Venetoclax has shown good responses there, and Venetoclax-based prognostic scoring in AML, secondary AML, etc., which seems to be a burning point at this point and important for clinicians to make prognostic decisions and therapeutic choices for patients. So the MDS genetics in last decade has seen several important revelations. This is one of the earliest paper published in the New England Journal of Medicine, which alluded to the mutations, as you can see over there, which have retained its prognostic efficacy even with modern therapies seen in multiple clinical trials, and goes on also to secondary AML, which is now not just a clinically defined subtype, but a genomically defined subtype, and which will be the crux of the talk today. There have been similar data about transplantation and MDS genetics, some of which was spoken this morning, but all this work ultimately led to the IPSS-M, which is a very novel prognostic scoring tool that uses cytogenetic changes, genomic changes in MDS, and highlights the gamut of prognostic modeling that could be used, especially with respect to something, let's say, like SF3B1, which could be further stratified based on the corroborative cytogenetic changes, other mutations, as could be seen here. So as we know, MDS with isolated SF3B1 consists of the best prognostic patients, but in association with other mutations like BCAR, BCAR-L1, TP53, not surprisingly, the prognostic beneficial impact of SF3B1 comes down. And this is known, this was discussed. But what is important also to understand is when we talk about prognostic scoring systems, we also need to include the type of therapy that has been used, which seems to be missing in a lot of the prognostic models in MDS as well as in acute myeloid leukemia. Now, this is one of the most phenomenal work that looked at the genomic heterogeneity of acute myeloid leukemia by Lippep Manuel that looks at the different cohort of mutations present in acute myeloid leukemia, and those arrows at the bottom point those mutations which are enriched in secondary acute myeloid leukemia, which consists of approximately 31% patients if you look at the figure on the right. Now, to talk about secondary AML, how did it move from a clinically defined entity of patients having MDS AML progressing to AML or therapy-related AML to a genomically defined group? So one of the earliest piece of work was from Lindsley et al., published in Blood 2015, which showed that these patients who have the mutations highlighted on the left tend to coalesce in the subgroup of clinically defined secondary AML, leading to the nomenclature of the secondary AML that is more devised by ontogeny and not just by the clinical therapy that was received before by these group of patients. And that leads to the evolution of newer thoughts, which includes inculcation of the genomically defined subset of secondary AML, both by WHO as well as the ICC, and they were similar in this front despite many other differences. Now, what is the approach to secondary AML? So you could have patients who receive therapy, that is radiation, chemotherapy. Then they go on to develop MDS, so that's therapy-related MDS. Then they progress to AML, so that's secondary AML, but in the background of therapy. So we could call these patients treated secondary AML. A patient could get MDS, does not receive any therapy, and then progress to AML, possibly a better subset. Then there are these de novo subgroup of patients with AML, supposedly the patients who harbor not so nefarious mutations, responds better to therapy, and conglomerates well with the favorable subtypes of acute myeloid leukemia. So this has been our clinical approach. And now we have the clinicogenomic approach, where we include patients with MDS genetics, and suddenly the de novo falls apart. We have a major group of patients with de novo AML, often sometimes young patients, no prior history of other malignancy or other therapy, no prior history of MDS, and they possess MDS-like genetic mutations, and them being called now as secondary AML. Also, therapy-related AML patients could and have always been found to have mutations which are not so good, whether it be -7, -5 chromosomal changes, whether it be problems with KMT2A, depending on the type of therapy that they have received, again now coming under the ambit of secondary acute myeloid leukemia. Thus, the true de novo AML population is now a very small group of patients, but indeed they have been always shown to do better than others. Now, coming to the Venetoclax story, after having spoken a little bit of the background genetics, Venetoclax was essentially a failed single-agent trial led by Dr. Konopleva and MD Anderson when she was there, led to very minimal responses when used as a single agent in patients with relapsed refractory AML. But as research in basic sciences moved forward, we realized that it essentially reduces the apoptotic threshold of cells and needs something to be added on to it for maximum potency in myeloid disorders, unlike in CLL, where it's efficacious as a single agent. And then we moved forward in the field, and now everything is fair in love war. And with Venetoclax, we have studied Venetoclax in CLL, in AML, in ALL, CMML, now even in CML, we are running a trial. But how has been the progress truly? So these are the data from the Viale A and the Viale C trial. Wonderful curves, splits early on, median survival doubles, especially with the HMFN, and some early snippets into the biology of the disease does show that even patients then clinically defined as secondary AML still do better when Venetoclax was administered to them. In the same year, a few months later, this correlative analysis was published by Dr. Donato from our group, which looked at patients who had durable responses with ven-based therapies, response which relapsed soon after, or primary resistance. And there appeared subgroups of patients primarily with TP53, complex karyotype, FLT3-ITD, who even if they attained responses, these were not truly clinically meaningful responses, and thus became the first palette on which determinants of response and duration of response to venetoclax were read out. Now, the VIALE-A and the VIALE-C trial led to the approval of venetoclax with low-intensity therapy with hypomethylating agent or low-dose-cytarabine. It has stood the test of time over the last 5 years, but at MD Anderson, we went ahead and are running some clinical trials. Also, several other groups are doing that to see the impact of venetoclax with intensive therapy, of course, in acute myeloid leukemia. And cutting short the chase to the trials, but rather this propensity-matched comparison, we do see that in patients with intermediate risk and adverse risk AML, when they are treated with intensive chemotherapy plus venetoclax, the responses, the duration of responses, and overall survival are better, probably, again, highlighting the important role of venetoclax in myeloid leukemia therapy. Now, in the midst of this, the ELN came up with their new recommendation that looks at new genes which could be counted as adverse risk. But importantly, these were taken from studies that looked at patients who were treated with intensive chemotherapy without venetoclax, leading us to this retrospective effort where we try to understand patients with splicing factor gene mutations in newly diagnosed AML and compare them with patients who were newly diagnosed without splicing factor gene mutations, looked at their treatment intensity, use of venetoclax, and their outcomes. Notably, there were no patients with core binding factor AML in the splicing factor group, so we excluded that from the comparison. Splicing factor mutations were common along with ASXL1 and 1X1, again underlying their secondary AML biology. These patients had higher risk ELN 2017, primarily again driven by the 1X1 and the ASXL1. Responses. So responses were, if you see the groups between the different splicing factor gene mutations, it was not much different. Overall, the responses of patients with or without splicing factor gene mutations were similar. But what is important here is to understand the figure on the top right, where you do see that even in clinically defined secondary and therapy-related AML, the splicing factor gene mutations were more common, and this is no surprise. But what is important, again, here is to understand the survival outcomes. The ELN read out that survival of patients with splicing factor gene mutations were poor, and that's why it was put in the adverse risk category. But when we look better at patients and stratify them based on the type of therapy they received, we look at low-intensity therapy, which is low-dose Ara-C or HMA unstratified. We do see that patients with splicing factor gene mutations, a very common secondary type mutation in AML, they fare similar to those who do not have these mutations. And when we substratify them based on their receipt of venetoclax, venetoclax seems to be improving the survival for all patients. Maybe the overall survival is slightly better for patients who have splicing factor gene mutations. Now, to understand further about the ELN story, we looked at patients who were younger and treated with intensive therapy, and we do see that in these patients, splicing factor gene mutations made slightly inferior survival outcomes. But when we looked at those patients who received venetoclax and intensive therapy, again, the negative prognostic impact of splicing factor gene mutations in overall survival reduced, letting us to believe that probably venetoclax-based regimens are important for these secondary type AMLs, not just in splicing factor gene mutations, but other subtypes, but the data is not shown here for that. In multivariate models, when we used different factors to look at young patients treated with intensive therapy and older patients treated with low-intensity therapy, we actually see that the presence of splicing factor gene mutations, when taken together with venetoclax, leads to slightly better independent reduction in hazards of death, whereas in younger patients, the hazards of death are not changed by splicing factor gene mutation. Now, what about AML with TP53 aberration? TP53 is a hotcake. Everyone is trying to attack it. Unfortunately, no combination has shown better than usual therapy. So we have taken this effort to do the retrospective analysis of a cohort of patients at MD Anderson. 90% of these patients were treated on different clinical trials. And we do see that patients, AML and TP53 aberration, again, a secondary defining genomic abnormality, Venetoclax leads to better responses, which could be seen figuratively as well as on the multivariate analysis. But these responses are not true responses. They could get into marrow CR, maybe true CR, but they really do not go into transplant, and even if they do, the survival outcomes are not superior than when you treat them with non-venetoclax containing regimens. Similar data were shown from the Viale A trial, where responses with venetoclax were slightly higher, but survival was not better than just HMA alone. So how does the bad influence the good? We know that the NPM1 is the poster child for venetoclax response. Here, the data becomes little conflicting. There are different groups mentioning the impact of secondary mutations on NPM1 in AML, but none of these groups have reported specifically the role of venetoclax, and that would be interesting to see. On the left, you see a huge cohort of patients from the AML Alliance, 936, who had NPM1 mutation, and they showed that when these patients were treated with intensive therapy, these patients did not have a drop in their survival outcomes, irrespective of the presence of other secondary mutations with NPM1. But when you look at the recently published data from 3 groups, combined data, we do see that patients who had splicing factor gene mutation with and other MDS type mutations with NPM1 fared poorly, but this has not been stratified for venetoclax, so those are efforts that we are leading now at MD Anderson. The need for better risk stratification in AML. So I moved from the year in 2022. We showed that venetoclax low-intensity therapy does well in the face of splicing factor gene mutation and others. So this called for better prognostic models. And 2022 ASH, this model was first shown by Donor and Donado, where they looked essentially at TP53, which is known to be bad. They also looked at kinase pathway mutations, predominantly FLT3 and RAS pathway. And if you remember the initial paper from Blood 2020, where they tried to draw the palette of determinants of response and duration of response to venetoclax, they used that data, and that split out very well what are the true indicators of survival and response to venetoclax. So we tried to copy this analysis at MD Anderson. And again, if you look at the figures on the right, for patients treated with low-intensity therapy and venetoclax, this model using TP53, FLT3, and RAS pathway mutations are able to split the curves very neatly. And truth be told, when we look at other secondary mutations, it didn't really matter. Now, just the last part of my talk is about secondary AML. These are clinically defined secondary AML. So these are patients who might not always have a TP53 mutation. They might not always have mutations which are known in MDS because they're clinically defined secondary AML. But the highest risk among this group are the treated secondary AML. So patients who have MDS, CMML, they receive HMA, low-dose Ara-C, not necessarily anandamide, and they progress to AML. Their survival and responses mimic what we see with TP53 biallelic acute myeloid leukemia, with median survival in the range of 5 to 6 months, a group that needs to be added in further risk stratification because they are not genomically classified, but therapeutically classified based on their prior treatment. Again, use of venetoclax in treated secondary AML. So similar to what we saw with TP53 mutated AML, the use of venetoclax in these patients who had treated secondary AML improved responses, but that did not lead to durable or meaningful responses. And as you can see, the survival curve on the left are superimposing on each other. Dr. Abaza spoke a little bit about venetoclax and high-risk MDS. This is correlative data from MD Anderson based on our phase 1 trial of HMA plus venetoclax and high-risk MDS. And you do see that DNA methylation pathways, chromatin modifiers, RNA splicing, mutations very commonly seen in MDS actually lead to better outcomes with venetoclax-based regimen. Similar data has been shown from the Mayo Clinic group, where presence of ASXL1, SRSF2, and IDH mutations leads to better responses with venetoclax-based therapies in MDS. Not true for TP53, etc., and that's known already. And very important data, again, from the phase 1b/2 trial of azacitidine with venetoclax in high-risk MDS, we do see that responders have almost complete disappearance of these common mutations that's seen in acute myeloid leukemia. So is there a biologic rationale to that? So when I was preparing the manuscript, almost at the same time, this data came out from Omar Abdul Wahab's lab, where they looked at patients who had splicing aberrations, or these mouse were made knockout for RBM1 gene, and they indeed became venetoclax sensitive, or their venetoclax resistant went away. There is data from 2017 from CLL also, where patients with CLL who were treated with venetoclax and had splicing aberrations, they seem to be doing better with venetoclax-based regimen, providing the biologic background to the clinical responses that we observed in our analysis. So in summary, addition of venetoclax to low intensity and intensive therapy in treatment of AML and high-risk MDS leads to better outcomes, probably in patients with these type of secondary AML and MDS type mutations. The phase 3 Verona trial data will be important to understand if the combination is indeed good and to look at the correlative analysis from that study. Newer prognostic models of AML are important, going beyond just what the patient presents with, but also to include what therapy the patient had and what therapy you're going to do to that patient. Altered splicing biologically improves venetoclax sensitivity, and this could become a potential pharmacological target in the future. That'd be all. Thank you so much.
Thanks so much. We have time for a question.
There we go, Dr. Stu.
65-year-old guy comes into your clinic. He's got splicing mutations, venetoclax Aza, or 3 and 7 base therapy.
Venetoclax Aza. Actually, just to build on that, and wonderful question, we have moved slightly beyond venetoclax Aza, and we are now doing a combination of low-dose dual nucleoside, the cladribine low-dose Ara-C venetoclax, very low-dose therapy, which alternates with HMA venetoclax for epigenetic priming, and that's what our primary mutation-agnostic regimens are at this. And at this time point, the data was, of course, not shown, but these patients also have very long duration of responses, and except for those 3 mutations, FLT3, ITD, TP53, and maybe a little bit of RAS, have good depth and duration of responses.
We'll see. Sounds good. Thanks so much.
Thanks a lot.
And so for our next speaker, we're now going to take this challenging subset, P53 mutant MDS. We've heard a lot about it this week. Who should we transplant, and what can we do about their disease?
And don't hit the player, hit the game, okay? Be kind, okay?
Good afternoon to those of you who are left. Thank you so much for giving me the opportunity to present today. It's been a real pleasure being here over the last 2 days, some fantastic sessions. I am an allotransplanter at the Dana-Farber Cancer Institute, and I'll be discussing who should be transplanted with TP53 MDS. No significant disclosures. I go back 20 years to this study because it's an oldie but a goodie. When we try to decide who to transplant with any myelodysplastic syndrome. And this question was attacked with decision theory by Corey Cutler and colleagues, where they visualized MDS patients in these different states, and the interventions were transplant at diagnosis, at leukemic progression, or at some time point in between. And they found with Markov modeling that patients with low or intermediate 1 risk MDS had maximal life expectancy with delayed transplantation, whereas those with intermediate 2 or high risk MDS had maximal life expectancy if transplanted at diagnosis. And patients could move from one state to another with a clinical event such as a new cytopenia or a new cytogenetic abnormality. Remember, this is before you could do NGS panels on every patient walking into the clinic. But this study has stood the test of time and has been replicated with the molecular IPSS presented by the Della Porta group at ASH this year. And this is really how we still make our decisions about who to transplant with MDS. You just saw these curves as part of a prior presentation, but this was a study mandated by CMS to show that transplant is effective in older individuals, and it is, as you can see from the separation of the curves. So as transplanters, we feel confident knowing who to transplant with MDS, except with TP53, and that's why that's a discussion and the subject of this talk. So TP53 is a bad actor. I don't need to belabor that for this audience. And just like in every other human cancer, it is bad in myelodysplastic syndrome, and to all known therapies doesn't respond very well. Approximately 20% of patients with MDS have P53, and this number is enriched in therapy-related and elderly patients. You also saw these graphs just a few minutes ago. This is a very important paper from 2011, which showed from Ben Ebert and Rafael Behar, which showed that P53 mutations portend for poor prognosis, even with transplant. And very importantly, also, they showed that if you had a P53 mutation, you were very likely to have complex karyotype. Almost 89% of the patients did. And that was particularly bad. If you had complex karyotype without a P53 mutation, you were not that badly off. And they actually ventured that maybe these patients should not get transplanted. This data was nicely replicated by Coleman Lindsley, again with Dr. Ebert, in a very large data set, almost 1,500 plus patients from the CIBMTR registry. So there were transplant and other clinical variables, but showed the same thing, that there was significantly worse overall survival with P53 mutated MDS, and this effect was irrespective of age. So in the subsequent years, a number of groups have tried to further nuance this prognostication. Can we look at disease factors or transplant factors to pull out patients who might potentially do better? I've already alluded to complex karyotype, but groups have looked at mutational burden with the variant allele fraction, the type of P53 alteration, which here I define as single hit and multi-hit based on recent work, which I think clinically this definition is actually helpful to us. The monoallelic and biallelic definitions really not something we have access to as clinical transplanters. So single hit is a single P53 mutation without any other alterations, whereas multi-hit is 2 or more P53 mutations or 1 or more point mutations in combination with copy number loss of heterozygosity, deletion, or chromosome 17 deletion by karyotype. And these are all metrics that we can obtain with our normal clinical workup. Presence of co-mutations has always been less important with P53, particularly biallelic P53. In the single hit patients, it may have some value, but if you have a biallelic P53 patient, firstly, they normally don't have a lot of co-mutations, and it doesn't seem to matter. Transplant factors, of course, fitness and comorbidities are always very important. In Coleman's paper, he did show that MAC and myeloablative and reduced intensity conditioning led to similar outcomes. And based on that, we do prefer reduced intensity conditioning because we do not want to add the additional toxicity of a myeloablative regimen when it's not going to help. Here is some data from Dr. Solomon, where he showed that variant allele fraction does matter if you use a cutoff of about 40%, but really tracks with complex cytogenetics, so I don't know that it additionally adds that much value if you already have complex cytogenetics. The Papin-Manuel paper in Nature 2020 did show that biallelic P53 is worse than monoallelic, but this was mainly in the pre-transplant setting. And really the cohort of patients who actually got transplant, this distinction, monoallelic and biallelic, did not really discriminate between the patients who did better and those who did not. So this is an important paper which came out last year and is a post hoc analysis of BMT-CTN 1102 by genomic stratification and came out of Coleman Lindsley's group and his postdoc. Here they define P53 just as we have discussed, single hit or multi-hit. In the donor and the no donor arm, the prevalence of P53 was similar, 28% versus 29%. And if you look at the curves on the right, you can see that with transplant, survival was much better than without transplant. This was a hazard ratio of 3.89, p-value of less than 0.001. The overall survival in patients who did get transplant was about 23%, which is dismal and is not what we are going for as transplanters. But it is still significantly better than not doing transplant. And if you look at the forest plot on the left, you can see that single hit versus multi-hit did not actually make a difference. This may be a product of small numbers, or it may be a true effect, but at least based on this study, which is really the only prospective look at this question, even though we get alarmed with P53 and even more alarmed with multi-hit, it does not help us in deciding who should be transplanted based on available data. So here is a practical approach to a difficult problem in the clinic when you guys hand over the patient to us to cure. If the patient has borderline transplant fitness and comorbidities, we counsel them extensively regarding the benefit and risk of transplant, because if you add the non-relapse mortality toxicity to the already high relapse rate expected, really benefit risk does not justify transplant. However, if the patient is fit, otherwise, transplant is an option and should always be done on a relapse prevention trial if available. If not available, based on the Vers-Lewis data I just showed you, you could offer transplant, typically a reduced intensity transplant, but caution the patient that the expected 3-year survival is in the 20% range. And if the patient is not accepting of this benefit and benefit risk ratio, it's better not to offer transplant, in my opinion, and in my experience, because that's some backlash when they relapse. So some of these clinical trials that we have that are undergoing or have been completed are outlined in this slide. We were very excited about APR 246, as were many in this room. Unfortunately, even with a relatively successful phase 1-2 trial with overall survival of 78.8% at 1 year, this drug is not available and is not something we can use. We have also been very interested in the Venetoclax plus HMA combination as maintenance. This was a trial led by Dr. Garcia and a massive effort with, I think we're just going to enroll the 100th patient. So far, the overall survival is looking pretty good in the patients who got maintenance, and about 50%, a little more than 50% had P53 alterations. So it remains to be seen where this will go in larger randomized studies, but it is certainly my go-to trial in the current scenario. As transplanters, we always want to think about modulating the immune system to prevent relapse, and attempts have been made with adoptive T and NK cell therapies, with graft engineering efforts without immunosuppression, as well as with checkpoint blockade, but so far, no home runs. And so I come to the other idea circle, the desperation circle, where we really need to understand a little bit better how P53 is evading the donor immune system before we think about modulating it. And this was the basis for our current project, which in the last few minutes, I want to show you some preliminary data, some of which has been presented at ASH and some which has not. Really came up a discussion between Dr. Anton and myself in clinic after yet another inevitable P53 relapse, that where maybe we should be looking at the immune system in addition to disease factors and look at the interaction between the two to see how P53 is evading GVL. And so we collaborated with Peter Van Galen and the Van Galen lab and Andy Lane using bank samples from our CMCF and analysis through our translational immunogenomics core. And we are collaborating with Dr. Zeisser for some future endeavors in this space. So just a note about GVL, graft versus leukemia effect is the mechanism by which allotransplant keeps patients in remission, and we do think that donor T cells are really the main effectors of GVL. Other cells such as NK cells are also being studied. And when we think about GVL and T cells, we also think about the TCR because a diverse repertoire of TCRs which recognize a wide range of antigens should be helpful in this context. And we know that a highly diverse TCR repertoire is a fundamental property of an effective immune system. Here we are looking at diversity as the number of TCR clonotypes. And clonality and diversity have an inverse relationship. If you look at these circles, the more diverse repertoire has many colored circles, so many unique TCR clonotypes, while if you have low diversity, your TCR repertoire is dominated by certain clonotypes, and you have low diversity and high clonality. So we set out to see if there were any immune signatures we could identify in the post-transplant milieu which would predict which P53 patients remained in remission and which patients went on to relapse. And can these differences predict relapse before it occurs? So we had 12 patients. These samples are hard to come by, but this was a study cohort. And we divided it into patients who never relapsed, who relapsed after a certain period of being in remission, and cohort 3 were patients who relapsed prior to 3 months. Those we considered really a progression of primary disease rather than immune escape, because in the first 3 months, there is barely any immune reconstitution. And so we really did not look at that group. So from cohort 1 and 2, all these patients got a uniform transplant regimen, a reduced intensity transplant with TAC methotrexate and T-cell replete grafts. There was representation of both single hit and multi-hit in both cohorts. And we focused on the 2 to 6 month, really the 3-month time point to see if we could identify different immune signatures. So we sorted viable mononuclear and CD3 positive T cells, and then performed 5' single cell RNA-seq and TCR-seq with 10x genomics. And using canonical gene expression profiles, we annotated different cell types, and then selected the T cells for further evaluation. Here is a snapshot of the final data set with 137,649 T cells and NK cells, but really the landscape is dominated by T cells, as you can see. And we found that there was a relative expansion of CD8 positive T cells in the patients who did relapse, but more importantly, it looked like the patients who went on to relapse had decreased TCR clonotype diversity at that 3 to 4 month time point, whereas those who remained in remission had increased T cell clonotype diversity at that time point. We subsampled the same number of cells for each patient and restricted it to the 3-month time point, and these results did not change. So there did seem to be a significant difference in these two cohorts, so we then overlaid T cell clonotypes in this UMass visualization. So if you look at the non-relapse cohort, you see many more colors, and each colored dot represents an individual TCR clonotype. And the clones are small, the number of clones are large, so it's more diverse with smaller clone size. In the relapse cohort, it's dominated by the blue and green colors because the number of clonotypes are lower, but the clones that are present are hyper-expanded. TCR diversity is not a new, it has been looked at in many different tumor types and often correlates with tumor progression. Back in the 1990s, there are papers which show that DLI can normalize the TCR repertoire over many months, but it's never really been looked at as a predictive biomarker and not in the P53 context. We were able to look at whether these cells were donor or recipient derived, and they are donor derived T cells, and they are primarily CD8 positive T cells. And the subtype of CD8 T cells which dominated the repertoire were effector and exhausted T cells. So this is our preliminary finding, more questions than answers at this point. But we do want to try and identify tumor cells at the time point when diversity is different. And I found Dr. Zhang's work very interesting, where he's looking at P53 stem cells, even when MRD is not visible. Gene expression analysis, so far we've seen that the genes which are more expressed in the relapse patients are genes involved in T-cell effector function. We're building low and high diversity GVL murine models to hopefully test out some interventions. And I think the most difficult part of this is determining antigen specificity of the most expanded T-cell clonotypes, but that is something we want to do as well. So I'll stop here, and thank you to my colleagues, mentors, and collaborators, and to Jacqueline, who really got me in touch with Peter. And happy to take any questions. Thank you.
This is such a wonderful talk. One way to interpret it may be that the P53 mutant leukemia is doing something that's generating this T-cell response. I guess the other way to interpret it is that you have either higher immunosuppression or some sort of a defect preceding transplant or going through conditioning, that you're essentially just have fewer T cells and they appear to be more hyperexpanded, and it's really not the failure of the TP53 in this cohort, but just a failure of immune reconstitution after transplant.
That's a great question, and I actually think I think you may be very close to the truth. I think this is an issue of immune reconstitution. We looked at chimerisms at that time point, and they were not different between the relapsed and remission cohorts. These patients look like they're in remission at this time point. But the causality of the TCR diversity readout is a bit of a chicken and egg. I mean, it's difficult to know what came first, and I think if we have to really look at it a little further with some of the future directions that we're looking at and validate it in a larger cohort. But honestly, I was quite surprised to see any difference because it's such a small number of patients, but it was, we validated in every way we could in this cohort, and it looked real.
I have a quick question.
Sure.
Thank you for a great talk. How do you suspect PTCy, because we use a lot of PTCy, effects on the T cells and or relapse in P53 mutations?
Yeah, great question. I mean, as you know, PTCy is a revolution in the field. I've been involved in many of the studies with PTCy. I'm a believer. And if you've seen Leslie Keen's data on the correlative analysis from 1703, which was recently published in the New England Journal, she did show that PTCy patients have lower TCR diversity in the context of GVHD. Of course, she didn't particularly look at P53 patients, and we are actually collaborating with her with those samples, with the 1801 samples, because it's a large data set and in a randomized study, and so we'll be able to look at a PTCy cohort to see if these results are replicated there or not.
Have you guys looked at in the patients that you studied for the 3 to 6 month time point where they were with immune suppression and their tapering? And did you see how that might have impacted the clonotypes?
So our practice at the Farber is to start tapering immune suppression after 3 months. So all of these patients were on full immune suppression at the 3-month time point, and they really hadn't had any other interventions. I mean, there were patients who went on to be on maintenance studies. We really don't do preemptive DLI at this time in T-cell replete transplants, but at the time point that we took the snapshot, they were all on full immune suppression. It would be interesting to see how that would change as you taper immune suppression.
One last question.
Sure.
So our group at MD Anderson has looked at inflammatory signatures in patients with TP53, and I think that just got Hussein Abbas in Nature Communication, and they found that interferon gamma-related inflammatory signatures were higher in TP53 early on and through therapy, not in a transplant context per se. So maybe that these patients have a different immunological background to start with, and then of course transplant plays havoc with that in whichever way. That's one. Two, the use of immune-directed therapies, whether it be magrolimab or, previously we had, Dr. Daver at our group had led a trial with PD-1 blockers looking at these high-risk group of patients to see if there is any way you could rescue the immune system, but both these trials did not show any benefit. The magrolimab trial has been called off, and we're reporting the phase 2 study from our data from center as well. So in the context of the failure of these regimens and the inflammatory signatures, how do you read out this reduced diversity of the T cell clones, and whether they actually are co-occurrent disease biology versus what mediates relapse post-transplant?
Yeah, no, that's a great question. I think the devil is in the details. When you think about mechanisms of immune escape, we know, for example, that in haplotransplants, loss of heterozygosity is a mechanism. Some tumors use downregulation of MHC. And PD-1 blockade has been actually tried post-transplant and with very limited success. So it almost seems that, that is not the right target. That doesn't mean that exhausted T cells are not playing a role, but PD-1 is not the target. And so I think our attempt is really to understand the mechanism of immune escape a little better so that we can come up with rational therapies, because it is hard to give preemptive therapies which have their toxicities to every patient, even with P53, although a little more justified there. So our hope is to identify some kind of persistent signature which will tell us, well, this patient is destined to relapse. And then you can intervene with a little more confidence, and the acceptance of risk is a little bit better. But I'm not sure checkpoint inhibition in its current form is the answer, because that has been tried and it doesn't really work.
Neither does anti-CD47.
Right.
Thank you all.
Thanks so much.
So we will we'll have a very elevator pitch based presentation. Now that we're transplanting everybody, including P53 patients,
Sold.
should we do anything to their disease before they go into transplant? And so we have a nice debate here between two transplanters, Dr. Zach DeFilipp and Dr. Nico Gagelmann, and two leukemia-based physicians, Dr. Shyam Patel and Dr. Jacqueline Garcia, to talk about the pros and cons of treating prior to transplant.
So, Dr. Patel, you come on down. We're going to present the cases. Very straightforward. We had wanted just perspectives from, U.S., ex-U.S. What are we doing? These are classic cases that present. We're constantly given, could you do more before we make a decision? So we thought this would be great. We did not ask anyone to select a pro or con, nor did we force them to. We kind of gave, what are you going to do in these types of scenarios, because they're very challenging. We have 20 minutes, so I know I told you guys 6. We're going to make it like a little bit less than that, so that way people can leave on time. And then here are the cases.
Absolutely. So, all right, so perspectives. Is it in the eye of the beholder? So leukemia and transplant, and from multiple institutions. And a couple questions to think about just to frame the cases. Should this patient receive cytoreduction? And if so, what would you give them? And then what type of bone marrow or hematologic response, if any, do you care about before you go to transplant? So our first case, it's an older patient, has MDS, 70-year-old, has hypertension, and has had progressive pancytopenia. Hemoglobin's 9, ANC's 0.6, platelets are down to 40 over the last 6 months approximately. Eventually makes it to your clinic. A bone marrow biopsy is performed. He has MDS with increased blasts. He has 11% blasts, the MDS/AML entity. It's hypercellular, 90% cellular marrow, trisomy 8, and he has mutations in DNMT3A, TET2, STAG2, and ETV6. His IPSS score would be high risk. His IPSS-R score would be very high risk, and his IPSS-M score would be very high risk. He's active, ECOG-1, he's interested in transplant, does not have any siblings or children, and he meets with the transplant team, but they're going to need a few months to find an appropriate donor. So that's case 1. Case 2, similar patient comes in, next patient in your clinic, 67-year-old woman. She has some heart disease. She had a stent 3 years ago. Seems like that is resolved. She had smoked and has diabetes, not insulin dependent. And her cytopenias are mild. She has a hemoglobin of 10, ANSI's 1.1, her platelet count is 79,000. She has a bone marrow biopsy as well. And her bone marrow biopsy shows 3% blasts, normal karyotype, and she has mutations in DNMT3A, SRSF2, RUNX1, and NRAS. And she has intermediate 1 risk disease by IPSS. She has an IPSS-R score that would put her in low risk, but her molecular profile puts her into high risk by IPSS-M. And so she's got an ECOG of 2. She's still pretty active. She's would be interested in transplant. She has 3 siblings, 3 children, and because of various family issues, they are not available. She'll have an unrelated donor available in 3 months. And so let's see what we do.
So obviously Dr. Patel and I are live. We each have a small set of slides. Our 2 transplanters will be virtual. So Dr. Patel, would you like to present yours?
Thank you, Dr. Garcia. Thank you, Dr. Brunner, for the invitation on this exciting debate. Here are my disclosures. So I thought a picture is worth 1,000 words, so I can briefly just illustrate this debate using this pictorial. In the middle of the picture, you can see a branch point, which is the key critical decision point for whether to give upfront transplant or to give HMA or some sort of cytoreduction prior to stem cell transplant. And as we know in MDS, with aging over time, there's a sequential accumulation of mutations, which at some point will manifest phenotypically as dysplasia. And at some point, that can manifest phenotypically as an increase in the number of blasts. And the question is, should we try to decrease the number of blasts before transplant, or just proceed with an upfront transplant? Some of the key points of this debate to consider broadly are, number 1, the disease biology of the MDS. As we know, no 2 MDS cases are created equally. And as we've seen in the 2 cases that were just presented, they differ by blast enumeration, they differ by risk assessment, by comorbidities. Another major consideration is whether that disease biology will be altered either favorably or unfavorably with the presence or the introduction of pre-transplant cytoreductive therapy. Namely, if you give pre-transplant cytoreduction first, would that lead to the emergence of resistant clones, or would it actually improve the disease by reducing the disease bulk? So we also have to think about the influence of MRD status prior to transplant and whether optimal debulking is preferred. The one downside could be that if a patient is heavily pretreated with multiple cycles of pre-transplant chemotherapy, they may actually lose their transplant candidacy due to deteriorating performance status. So there are various logistical considerations to consider. Transplants can be delayed if repeated cycles of HMA or cytoreduction are given. It's possible that the donor could also be lost, or we might lose donor availability. So in case 1, I was thinking just to kind of redefine this case using the ICC. And as we know, the ICC kind of questions the blast threshold between MDS and AML, and there's somewhat of a blurred distinction in that continuum. So in this case, with 11% blasts, one might respectfully argue that this is actually a case of what we would call MDS/AML with myelodysplasia-related gene mutations. And by risk assessment from the ELN 2022, given that the patient has a STAG2 mutation, this would be considered in the adverse risk group. So I would like to kind of respectfully focus on the blast enumeration in case number 1 to support the case. So for case number 1, there was this article. It was a retrospective study by the Chinese Academy of Medical Sciences and the City of Hope, looking at 80 patients, and this is over about a 13-year period. What they found is that just in brief, if patients achieve complete remission with pre-transplant cytoreduction, their 3-year overall survival was 80%, and that's highlighted in yellow. However, if they did not undergo pre-transplant cytoreduction, the 3-year OS was only 56%. So this was in support of pre-transplant cytoreduction for this subgroup. And the inclusion criteria were more so based on the WHO-HEM4 revised, which was MDS EB2 and AML MRC. But I thought that was similar to the patient in case number 1. For case number 2, this is a little bit of a different case because this patient has 3% blasts. And in this case, there's certainly an argument in favor of upfront transplant. So there was an article in BBMT, which was a retrospective study of 165 patients. And just to summarize here, in yellow is the highlighted key features. The 5-year overall survival rate for upfront transplant was 61%, and it was lower for pre-transplant induction. It was just 50%. So for a patient with a low blast number, it might not be worth trying to debulk first because potentially you could run into other issues, which are nicely shown in the Videza Allo study. So in the Videza Allo study, there was a group of patients, about 31% of people who had progressive disease, and they had to discontinue the study prematurely when they received upfront azacitidine. And about 33% of those patients were not able to achieve an allo transplant. So for case number 2, I would respectfully argue against pre-transplant cytoreduction and just favor proceeding with transplant. To summarize my opinions here, going back to the original illustration, at the key center branch point, I would say for case number 1, I would favor pre-transplant cytoreduction with HMA therapy based on the blast enumeration, and perhaps you can get better engraftment if you decrease the blast percentage. For case number 2, where there were fewer blasts, I would say it might be worth just proceeding with an upfront transplant so that you can avoid the potential deteriorating clinical status and avoid the potential for delays in stem cell transplant. Thank you.
Thank you very much. The patient appreciates your visit and consultation and goes to a second opinion with Dr. Garcia.
This never happens, going across town for a second opinion. So thank you for your time. So I'm going to present the leukemia perspective. These are my disclosures. We'll skip this, you know the cases. We've already heard from Dr. Abaza a summary of the phase 1b MDS trial with azacitidine venetoclax showing that it's safe and effective. Nearly 40% were able to be consolidated with transplantation. And so the question is, since responses can be expected in the majority of patients with this cytoreductive therapy, more so than what we would expect from HMA alone, the question is whether or not this would be a good cytoreductive bridge. And what did we learn from the post-transplant outcomes that Dr. Garcia Marrow presented at ASH? Well, we know that it's safe and effective bridging agent. The patients, we had to decide as investigators at the time of study entry, and this is a bit subjective, who we thought could go to transplant. It was an interesting study because we didn't have to preclude those that were going to go to transplant at some point. At that time, the CTN study had not yet reported. And so we indicated roughly about 40% were likely to go. And at the end of the day, about 40% ended up going to transplantation. And I think this really juxtaposes against the German study where many patients that did get azacitidine treatment were just unable to move forward, whether it was feasibility, toxicity, or disease progression, or ineffective therapy. One might argue that maybe HMA alone may be insufficient. The 24-month post-transplant survival is quite excellent as well, suggesting it could be safely given without making a patient too sick prior to their RIC transplant. Importantly, our colleagues, Dr. Peterlin in Europe, presented a study at ASH and then the subsequent paper. Many of us use the example of the responses as an indication of why we had to change response criteria for MDS. So this was a very valuable paper in many ways. But what he was able to demonstrate in a small study of 31 patients was that giving Vyxeos to patients with high-risk MDS, generally with greater than 10% blasts with intermediate 2 or high-risk disease, was able to translate into an effective bridge. Nearly 29 or 30 out of the 31 were able to be transplanted, so they did what they intended, and they were able to demonstrate no treatment-related deaths, which is actually a major concern of ours when we give patients with MDS intensive or conventional intensive chemotherapies. And in their early readout, the 12-month overall survival for this cohort that went on transplant was 81%. Of course, longer-term follow-up will be required. This thus suggests that these are two potential regimens to offer a patient that has MDS/AML disease, or disease where the burden looks to be concerning, especially because with patients that go to transplantation with MDS, the majority are going to be above 60. The majority will receive a non-myeloablative strategy. And so the chances of a GVL are really dependent upon how much disease is going in. Patients have to make it to the 6-month post-transplant time point without converting or relapsing to secondary ML or coming back with MDS in order to enjoy the benefits of transplantation. So what have we learned when we've taken a look at what patients get through comparator studies? This is one of my colleagues, Dr. Shyam, who will be joining our faculty this year. He did some lovely work within a multi-institutional study, taking a look at patients that received 7 and 3 versus HMA-VEN versus CPX-351. This is a retrospective study. How did patients fare? I'm just showing you one piece of the pie here where he had specifically studied the cohort that had molecularly defined secondary AML, which is defined by my colleague, Dr. Lindsley, with the genes shown here on the left. He went on to study, well, how did those patients do that went on to transplantation? And based on the therapy received, as you could see from the Kaplan-Meier curves, there's no space in between the overlap. So maybe the treatment on the way there was not so significant. And importantly, what he did demonstrate is that survival can be meaningful for this cohort. This was obviously retrospective, no control arm with here because it's not prospective, but the median overall survival was 60 months. So what did I learn from this? It's not entirely clear when you look back at patients which regimen you should choose. Of course, there are going to be people that drop out because they didn't respond, but moving to transplantation, if you're going to choose to treat somebody, you should choose to consolidate them and not make that decision later. So, and what did my colleague Dr. Lindsley also show us in that New England Journal paper in 2017, where he had combined the MDS patients and took a look at the molecular genetics that prognosticated outcome. He was able to pull away some details of some genetic subsets. So not only, just as Dr. Gooptu presented, augmenting intensive conditioning didn't look like it would matter for those with P53, but when you had a RAS pathway mutation, you could potentially eliminate the poor outcome with RAS pathway if you were to offer more of a MAC versus a RIC regimen, showing that maybe if you could give more, adds a little bit more beef to your conditioning or your transplant strategy, you might be able to overcome these pathway mutations. And so what does that lead me to conclude? Well, maybe cytoreductive is in the eye of the beholder. Maybe we shouldn't just start in the beginning. Maybe we should continue it throughout the transplant process. So I might argue, I do have a transplant trial, so I am personally biased, that maybe we should continue some reasonable, gentle, safe cytoreductive therapy after initial treatment to get patients to their RIC transplant without further delaying them. So this is the basic backbone for a trial that I've been working on in the transplant group for the last few years. And you see there's part 1, 2, 3, 4 because I kept amending the study because it was going well. We kept adding additional elements. The basics are our institution gives Flubu to reduced intensity conditioning. We asked a simple question, can we add Venetoclax in people with high-risk disease features with MDS or AML? We let them get their standard GVH regimen. And initially, in the first cohort of patients, because we had philanthropy only, I didn't give them maintenance. We followed them for survival and did fancy genetics. As we got pharma support, we were able to add on maintenance in part 2, which was Venetoclax plus azacitidine, and then we were able to then give Inqovi plus Venetoclax with additional pharma support. And because of the recent Tian study altering our standard of care for RIC, we now have an ongoing PTCY cohort with continued azacitidine Venetoclax maintenance. So just to be brief, to show you what we found, this is a swimmer plot shown here on the left. It's very busy, but the point is that we see patients coming in with high-risk disease features with different responses. Those shown here in the pink box on the left that don't have a blue color came in with active or morphologic disease that you could pick up. In our trial, we were able to demonstrate the 2 years overall survival is about 67% if they were able to get conditioning therapy and move on to maintenance therapy. What does that mean in details? I'm not advocating for Venetoclax. It's the idea that we can augment conditioning chemotherapy. It can be delivered safe. Especially it should be looked at with additional small molecule inhibitors. And this is where I might argue that maybe we should do a little bit more with looking at MRD. And this might help us to identify patients that should truly get this continued cytoreductive therapy. So here in collaboration with Coleman Lindsley, we did duplex level, research level sequencing with a VAF sensitivity of 0.01%. Shown on the right is a swimmer plot. What's in color means that there is a detectable molecular MRD. When the circle clears, that means we're able to convert patients. This is not a randomized study, but from 22 patients with well-annotated samples and MRD available, including flow and genetic MRD, we were able to demonstrate that though nearly 100% of patients came in with molecular MRD, so persistent disease, we were able to clear patients, whether or not it was for maintenance or just what was expected with GVL. We were able to demonstrate that they were able to receive therapy, and clearance of MRD is in fact possible. So I would advocate for potentially continued low-dose cytoreductive therapy so we can actually get patients to transplantation. And I'll end there.
Okay, so the patients get their instructions from their leukemia docs, and now walk over to the transplanters and see if they align or if they're going to have to go back and ask for or getting therapy or not.
All right. You guys can hear me?
Yep.
All right. It's not letting me share my slides here. See if this gets updated. Beautiful. So this will be super rapid fire. That was the what I was asked to opine on these two cases from a transplant perspective when this patient is sent to me by Dr. Brunner. So I'm just going to go at these three questions for each case. So should the patient in case one receive any cytoreduction? So in my perspective from bone marrow transplant, the answer there would be yes. My reasoning would be that it's pretty well established in this first patient who initially presents with 11% blasts, that having a lower blast count going into transplant is associated with less relapse. I think in this first case, I don't think that the molecular data really changes my perspective of this patient's disease. We obviously don't want this patient to progress any further also, and given the scenario, I don't have an immediate transplant to offer this patient as the transplant, it seems to be at least 3 months away. So from a practical perspective, moving forward with some version of HMA-based therapy seems like the right thing to do. What kind of response are we looking for in the bone marrow on this? So kind of based on that, ideally we're looking for the bone marrow blast percentage to get below 5% or somewhere thereof. And I think one thing here, like the first patient, I believe is 70 years old in the prompt. You know, this patient's not going to be getting an myeloablative transplant. And what we know is that if you look across different studies, the relapse rates are going to be potentially high with these reduced intensity transplants. It could be, depending on the study, depending on the exact disease risk, could be 40% or more. So I kind of feel the better response kind of we see going in, I think that's ideal. Transplant considerations. So when I'm talking to patients and they're usually asking this question about transplant, I do feel that the CTN study 1102 and the Vidasa Allo studies are very important studies. They're randomized, at least by biological assignment, transplant, no transplant. And this prompt is a patient who would be representative of those studies. Those studies defined their MDS risk by IPSS, which this patient had, would have been kind of in that category, the right age and the right donor conversation, probably saying that we're looking probably at a matched unrelated donor. And then I think it's also good to keep in mind here that, as has also been discussed, while MDS therapies are improving, so are transplant practices. And if you think that you could give this patient a reduced intensity, matched unrelated donor with PT-Cy-based GVHD prophylaxis, this would be associated with good overall survival and low rates of GVHD. I think one thing that was brought up with these last 2 points that I'll also just comment on is, you know, is there a risk in patients getting HMA therapy and then potentially not being able to go on to transplant? And I would just kind of question that a little bit because if a patient's disease progresses while getting a few cycles of pre-transplant therapy leading into transplant, I think that that's probably a warning sign that they would have relapsed pretty quickly with their transplant, especially reduced intensity one. And also from that same perspective, if the patient's clinical status deteriorates to the point that they're not transplant eligible anymore on HMA therapy, I would also question the fitness of that patient in terms of a transplant platform. So going into the second case, this is a little more controversial or novel because initially by traditional like IPSS, IPSSR, the patient was not as high risk, but then it's the molecular which kind of upgrades their risk. And they also are coming in with a low blast count. So should this patient receive any cytoreduction, so I will take the middle ground and say it's unclear. And for that same reason that, you know, from a Gestalt perspective, it seems that if you follow the thought process that lower blast counts might be better for terms of treatment outcome, you know, could reduction or clearance of mutational burden kind of have a similar effect? The question is maybe, what we don't know. An HLA match donor may not be ready for 2 to 3 months, but this patient did have some siblings and some children. So the question is, if you wanted to move to transplant a little more quickly without cytoreduction, would you consider a related donor who is maybe older, or maybe a haploidentical donor, depending on where you transplant? What kind of bone marrow response we might be looking for? So regardless whether you treat this patient or not, if there's going to be a gap of even a few months before going to transplant, I would repeat the bone marrow biopsy just to kind of ensure there's been no overall progression. If treated, you'd like to see some improvement in the allele frequency or clearance of mutations, but I'm not sure how mandatory that is, and therefore you may only need to give them a cycle or two before deciding that they are fit to go to transplant. And as long as the molecular profile is stable and the blast count remains below 5%, I think going to transplant would be fine. And lastly, you know, just pointing out, this patient would not necessarily be represented in that CTN study or the Videza Allo study. And I think that's something to keep in mind. Nonetheless, I think it's more than reasonable to take this patient to transplant. If you look at the x-axis on the IPSS-M's graphs, you know, that x-axis goes out by 10 years. So I think as a high-risk patient, we know that they are not on a great trajectory, but I think we have potentially, depending on individual patient considerations, a little bit of time. But I would still probably move to transplant within the first 6 to 12 months before those curves start to separate too much. And then when you're thinking about patient specific considerations, this patient had more significant cardiac history. You would want to get them in to see a cardiologist, try to do what you can do to optimize their comorbidities and as well as their performance status before ultimately probably moving forward with transplant. So with that, I will stop sharing.
Excellent. All right. Thank you. So far, our patient one has heard a pretty consistent message across 3 physicians. Let's see if our last transplant perspective changes anything. You may need to unmute.
Yeah, can you see my slides?
There we go. Perfect.
And can you also hear me?
Yep.
Perfect. Okay. Thank you so much, first of all, for having me. It's a real honor to be here for the second time, and I really enjoyed the discussions and the presentation so far. First of all, I must say, I must congratulate Dr. Brunner. I would say we need to have, first of all, NGS for all patients who also get to the transplant, no matter what they have, MDS, MPN, AML. And the second thing is that I would not agree upon. I think that neither MPN nor MDS nor the AML community do very well in generating PROs. So I think the whole community needs to do better, especially when we talk about continuous treatment with cytoreduction before transplant, before such intensive treatment. So we need more PROs in general in hematology. But I'm really, really happy that this was brought up. I'm very happy to be here, but I'm also very unfortunate to not be there with you in person. I'm unfortunately here in the rainy Hamburg while you are all in Bethesda, but I'm very happy to be part of this discussion. And I'll just jump right into it. I can accept a lot of comments that already have been made. I would just like to point out, as you can see on the right-hand side, that if we talk about more than 10% marrowblasts, the current recommendations or consensus already accepted that we need to do cytoreductive therapy. So probably the first case is already solved, as most of my co-presenters already alluded to. And the other thing is that we need to be aware of, we have this wonderful new tool, the IPSSM, and I think one of the most astonishing findings of the IPSSM was that we now have one clearly high risk group for post-transplant relapse. And this is the very high risk group, which both of the patients are or have very high risk IPSSM. So clearly both of these patients have high risk of relapse, no matter what kind of treatment they get. And what will be published and what has already been talked about is that the using the IPSSM for deciding whether or not patients need to get transplantation helps us in saying that patients with very high risk or high risk IPSSM, they benefit from early transplant. So the earlier the transplant for these patients, the better. The problem is whether, as Dr. DeFilipp just said, is he would consider 6 to 12 months of transplantation for case 2. I don't know whether this is really the more rational reality in the US, but if we talk about in Europe, if we talk about early transplant, we usually talk about 3 months, not even saying some patients 2 months. So clearly, patients benefit from early transplantation when they have very high risk or high risk IPSSM. And the other point I would like to make is what we showed in our multi-center cohort from European centers, but also from Cleveland Clinic, is what you can see on the left-hand side and at the top, that the IPSSM in our cohort was somehow valuable, especially when you talk about high risk, very high risk, but clearly not every mutation really counts. And what we could clearly show on the right-hand side on the top end, but also on the bottom, where we just did a proof of concept, simple molecular model for MDS transplant model that also has been shown quite a few years ago by Matteo Della Porta and colleagues, that usually only, if we really talk about the significant mutations, this is only the TP53 mutations. And I would also like to congratulate Professor Senagapati and other colleagues who presented before me that alluded to the role that TP53 and MDS in the transplant setting may be solely quite prognostic for worse overall survival, no matter what they have, multi-hit or single-hit. And that's what we also see in reality. So on the one hand, we have the very high-risk IPSSM, and then we know only TP53 mutation really plays a role. So both of these patients, in general, they have clear indication for stem cell transplantation, and both are, in my opinion, eligible. And this has also been talked about. I cannot say anything more. The only thing that we maybe all know now is that azacitidine from these trials from Professor Kröger alone will not do the job. So in our reality and clinical practice, we believe that the addition of venetoclax really makes a difference because of inducing deeper responses to transplant and also earlier responses. Vidaza usually only shows responses a few weeks later than venetoclax. And that's why if we have a patient that is clearly progressive, not only by blasts, but also by thrombocytopenia, anemia, fatigue, increasing LDH, etc., all these subtle signs that show us that the patient is really progressive, not only by the mutation type, there we clearly see the relevance of the combination of venetoclax and Vidaza. On the other hand, what I would just like to point out when we talk about AML or secondary AML, there was the study that was plenary at ASH in 2022, is still not published, maybe because of not such positive signs, is that if we compare sequential conditioning with direct directly undergoing stem cell transplantation does not seem to improve outcomes, even with slightly higher complete responses. So the problem that we all face, and that's why has already also been shown, but I would just like to point this out to maybe start into the discussion, is we clearly show across studies that has been shown here by a meta-analysis, also including the German study by Professor Schröder that has been shown before, is that cytoreduction does not really need an absolute benefit regarding overall survival, cumulative incidence of relapse, etc., but does induce responses. And we see that complete response at time of transplantation, even in MDS, has improved outcome. So this is, I think, quite a conundrum that we all face, is what kind of patient does really achieve response? And in my point of view, I would accept to say we clearly don't know yet, even in the current era with molecular mutations. But I would accept to say that this first case would definitely need some kind of cytoreduction to get transplant as soon as possible, while the other patient needs a transplant, but maybe without cytoreduction if he or she can make it until then. No matter what the comorbidities are at the moment, so diabetes mellitus, etc., in my point of view, would not defer transplantation in that case. And with that, I would like to thank you all and happy to discuss the two cases. Thank you.
Thank you all. It sounds like a surprising consistency with messaging. So we'll see. Maybe that was planned. I'm not sure.
Yeah, so when we consult our colleagues for our patients that they wish us to do things to, I think that they should take this and agree cytoreduction is reasonable with excess blasts. Are cases that are clearly evolving. In lower risk traditional cases with high risk IPSSM, they really should be considered and optimized quickly for transplant, and to be creative about how we cytoreduce our patients, whether it's on a trial, and to think about strategies beyond conventional intensive chemo so we don't make them too sick.
Thank you all for sticking